Good morning. Today we convene our hearing on the updated U.S. public health response to the Ebola outbreak for the Subcommittee on Oversight and Investigations. I'll begin with a 5-minute opening statement. Yesterday, Dr. Frieden, you shared with me a well-known quotation worth repeating: "Life can only be understood backwards, but must be lived forward." Today, we will review the lessons learned so far from the Ebola epidemic in West Africa and the plan to move forward, as the administration asks taxpayers for $6.2 billion in new spending to fight this deadly outbreak. So I want to see a plan that is simple and direct. Number one, prevent Americans from contracting Ebola. 2, treat those who contract Ebola effectively. And 3, stop the spread of Ebola at its source in West Africa. On the side of Ebola, however, its goal is to spread, kill, mutate, and repeat. There's no cure or vaccine, so we have to work together to break the chain. The steps we must take begin with erecting a strong perimeter of defense. That's why I outlined 10 recommendations at our last hearing, which included a ban on non-essential commercial travel, a 21-day quarantine or isolation for those who have had hands-on treatment of an Ebola patient, upgrades and training for personal protective equipment, designating specific Ebola-ready medical centers, accelerate development of promising vaccines, drugs, and diagnostic tests, additional aircraft and vehicles capable of transporting American medical and military personnel who may have contracted Ebola back here for treatment, additional contact tracing and testing resources for public health agencies, and information for Congress regarding any resources needed. Some of these measures have been implemented, and others are still needing to occur. Our role here is to all work together to help define the mission and ensure the policies put forth are straightforward and flexible to accommodate the ever-changing nature of this Ebola outbreak. Like Occam's razor, the best solution is the simplest one with the fewest assumptions. As we've seen, missteps are caused by ignorance and arrogance. They are corrected by knowledge, humility, and honesty. Let's consider some of the false assumptions the Federal Government's response has been based upon. Any hospital could treat an Ebola patient. A negative Ebola test result means a patient doesn't have Ebola. But just this week, a physician from Sierra Leone died after being flown to Nebraska for emergency treatment after initial tests showed a negative result for the virus. His colleagues are now in quarantine, causing even greater anxiety in a medical profession that has already lost more than 500 to Ebola. Hospitals and healthcare workers were to have some proper guidance on personal protective equipment. Self-isolation and quarantine orders aren't necessary. It was said. CDC guidelines do not require a 3-week self-isolation period for healthcare professionals who have been treating Ebola patients in West Africa. It was said that these volunteers can return to work immediately. But the hospitals I talked to did not agree. I asked an ER doctor from my district about whether any of his colleagues volunteering in West Africa could come back to work immediately. He had a simple response. And I quote him, and he said they should stay away. The administration continues to oppose travel restrictions and quarantines, yet respected institutions have such policies to ensure public health is protected. The Department of Defense has a quarantine policy as well as many local hospitals and medical institutions throughout the U.S. It's impossible for the American people to understand why the government would have one standard for the military and yet another standard for people who may have been in the same or possibly more perilous circumstances. Consider the cost of the administration's position. Senator Schumer has asked the federal government to reimburse New York $20 million for the costs associated with the 500 healthcare workers it took to prevent an outbreak in New York City because of the case of Dr. Craig Spencer. Now, the taxpayers have every right to ask, wouldn't it have been more cost-effective for the administration to instead require all returning healthcare workers to adhere to a 21-day isolation policy? We all need honesty and humility today. The American public is fine with a doctor who says, this is our plan based on what we know today. But as the facts change, as they most assuredly will, then we have to change our approaches. The patient and the public expect that. Now, Anthony Fauci of the NIH has said we should not look at the what-ifs. I categorically disagree. That is exactly what we need to do, what Congress needs to do, and everybody involved with this needs to do. What if the outbreak migrates to other countries? What if the outbreak extends to other continents? And if we get new information that says a change in policy is needed, tell us what you've learned and why change is required. As one example, we have set up screening protocols at 5 different airports to accept passengers from West Africa. Is this complex approach the easiest and safest way to deal with an Ebola threat? Are we hoping that we will be lucky enough to catch each potential carrier? Can we track the hundreds or perhaps thousands who might otherwise have been exposed if we have 5 U.S. arrival points, countless potential destinations, and numerous connections through Europe. With a disease that has no margin of error like Ebola, I'd rather be good than lucky. We need to consider whether there should be a simpler approach of one arrival point that would allow us to easily track the returning aid workers and government professionals coming from West Africa. The administration must also review whether government charter flights are needed to help get aid workers to West Africa, since many commercial airlines have ceased traveling there, and they also have concerns about shipping supplies to Africa. I'd like to ask the administration's Ebola czar, Ron Klain, about this issue, but when we asked for him to appear before our subcommittee, we were told that he, quote, wasn't ready. Another congressional committee made a similar request, and I understand they were told that the White House Ebola response coordinator had, quote, no operational responsibility, unquote. But for very few press interviews, this individual seems to be missing in action. No wonder the American people have concerns with the administration's response planning. We want to clear that up today, and we have good panels to do that. The public is given plans that keep changing from agencies that sometimes feel paralyzed, led by a czar who isn't ready against a disease that is killing more every day. Well, we stand ready to work with the administration to keep the American people safe from the Ebola outbreak. I welcome all the witnesses and look forward to learning more about the latest public health actions on Ebola and more details about the emergency funding request. I now turn towards Ms. Castor for 5 minutes for an opening statement.
Chairman Murphy, thank you very much for holding today's hearing, the second that we've had on the Ebola outbreak. And at our hearing last month, Americans were rightfully concerned about the news they were hearing. It was just weeks after Thomas Duncan arrived at Texas Presbyterian with Ebola, and just days after two nurses who had been treated, who had treated him, had become infected. In response to these cases, the CDC updated their protocols for treatment of Ebola patients and issued travel guidelines for those who had treated or been exposed to Ebola. Our hearing back then was held just 3 weeks before the election, and it seemed that much of the discussion of quarantines and travel bans reflected political concerns instead of the advice of public health experts. But today, when we look at where things stand with regard to domestic preparedness, we're in a much better place. No cases of Ebola have been transmitted to any member of the general public in the United States. With new procedures in place, and with the exception of Dr. Craig Spencer in New York, no individual has unknowingly entered the U.S. while affected with Ebola. Airport screening and new CDC monitoring guidelines implemented by state and local public health departments are in place, and we have successfully treated 8 Ebola patients that have entered U.S. hospitals. I want to give credit to these hospitals and healthcare professionals that have treated these patients. The professionals at Emory University, the NIH, the University of Nebraska Medical Center, Bellevue, and Texas Presbyterian. Their readiness has made a huge difference. And I want to welcome Dr. Gold from the University of Nebraska and thank him for sharing his expertise today. Unfortunately, the news from West Africa is not as good. While case counts in Liberia have slowed, there continue to be rapid increases in the number of Ebola cases in Sierra Leone and Guinea, and officials are now concerned about the appearance of Ebola in Mali. And that, Mr. Chairman, is why we need to continue to focus on the U.S. response in West Africa. It is a credit to our country that we are leading the effort to end the epidemic in West Africa, and the early results from Liberia indicate that our efforts and the efforts of our partner countries can make a real difference, but there is still much work to do. I want to acknowledge all of the medical professionals who are doing that work, and in particular say a few words about Dr. Martin Salia. We learned yesterday that Dr. Salia, who had been flown to Nebraska for treatment after developing Ebola while working in Sierra Leone, died from the disease. We send our condolences to his family and acknowledge his bravery and selflessness in helping fight this disease. West Africa is balanced on the edge, and if our efforts and the efforts of the World Health Organization are not successful, millions of people in these countries facing a looming humanitarian crisis will continue to suffer. And I am glad that Mr. Isaacs from Samaritan's Purse is here to give the perspective of the international aid community on the West African outbreak. Mr. Isaacs, your group and other groups like yours are doing difficult but critical work, and you deserve support. We're now in a much better position to address cases of Ebola that appear in the United States than we were a few months ago, and I appreciate Dr. Frieden, Dr. Lushniak, Dr. Lurie, and Dr. Lakey for joining us today to share lessons learned and tell us how we can continue to improve and move forward. And I'm also looking forward to the perspective of our witnesses on the administration's supplemental Ebola budget request. It's critical that Congress support this appropriations request. It would support domestic preparedness, help fortify 50 Ebola treatment centers nationwide. It would support the development of treatments and vaccines for Ebola, and it would support USAID and the U.S. military in their critical efforts to eliminate Ebola in West Africa. Mr. Chairman, I suspect that in the year to come we will have our share of discussions over the budget, but I know we all support the goals of the President's Ebola outbreak plan to combat it, and I hope we can move quickly to provide the requested appropriations. Thank you, and I yield back.
Generally yields back. Now recognize the Vice Chair of the full committee, Ms. Blackburn, for 5 minutes.
Thank you, Mr. Chairman. I appreciate the hearing, and I want to say welcome to all of our witnesses. We appreciate your time. I think we have to realize with the nearly 15,000 cases and over 5,000 deaths that this Ebola epidemic is the worst since the discovery of the virus in '76. And you need to look at what the precedent is there. 2,400 cases, known cases of Ebola prior to this outbreak. So we know that this is something that is going to be difficult and take some time to deal with, and we appreciate your efforts on that part. And there is a little bit of good news coming out of Liberia. There is also kind of a mixed bag of news that is coming out of the region, and it all leads us to look at the magnitude of the situation in front of us, as well as the human-to-human transmission of the virus, which has drawn attention to the need to be better prepared to keep Americans safe. And that is our goal. You know, most Americans believe it is the job of ASPR and the job of the CDC to keep Americans safe from infectious disease, and that all efforts need to be on the table when it comes to keeping Americans safe. Don't take anything off the table. The chairman mentioned some of those suggestions that were made at the last hearing. Indeed, yesterday I was at Fort Campbell with some of my troops who are over there now trying to build the hospitals and are training their medical personnel. And I think it is of concern to us that the administration has been opposed to travel bans and to quarantines, items that we think might work. Even the Institute of Medicine recently held a workshop where researchers raised a number of questions about the characteristics of the Ebola virus. They concluded, and I'm quoting, "Many of the current risk quarantine policies and public health mitigation measures could be better informed and more effective if the means and potential routes for transmission were more thoroughly characterized. Until we know more about the nature of the deadly virus, it seems prudent to keep all common sense measures on the table." And with that, I yield to Dr. Burgess.
I thank the gentlelady for yielding. Thank our witnesses for being here today. Dr. Lakey, good to see you again. This epidemic will surely go down in history as one of the most serious public health, from a global perspective, one of the most serious public health crises of the last 100 years. At our last hearing, we had a great deal to discuss, and certainly many of the brave pronouncements from middle of September were found to be non-operational by the middle of October, and there were failures in dealing with this crisis. Certainly communication was lacking. Systems and protocols broke down, and provisions that we all thought were readily at hand were never in place to begin with. I hope we know better than to let this happen again. This summer's emergency, to me, emphasized one thing, and that's have a lot of humility when you're dealing with this virus, because it is difficult to predict. As a physician, one of my biggest concerns since July has been the safety and the protection of healthcare workers. I want to thank the CDC for always being responsive to my telephone calls over the last several months, and the various conference calls that we had over the summer were helpful. And I got to tell you something, until you have this damn thing in your backyard, it's just hard to estimate how it's going to affect daily life on so many levels. Sure, we had a hospital that was hurt by the crisis. We're probably lucky we didn't have more than one that was hurt. Trash collection, sewer treatment, school districts, everyone down the line was affected by having this virus in our area. So we do have to take great care and closely follow the epidemic in Western Africa. It is important that that be brought under control. I also have to tell you, I am grateful for the services of the hospitals that have handled the known Ebola patients, but I am much more worried about that unknown patient who could walk through an emergency room door at 3 o'clock tomorrow morning, unknown to anyone, unannounced, and provide the same set of circumstances that we've already been through. I'm not sure we've learned entirely the lessons. Thank you, Mr. Chairman. I'll yield back.
Gentleman yields back. Now recognize the ranking member of the full committee, Mr. Waxman, for 5 minutes.
Thank you, Mr. Chairman. I'm pleased you're holding this hearing. This is a very important topic, and it's appropriate for Congress to learn about it because the American people want to know what's happening and want some answers. But I picked up a couple comments from the other side about having humility, learning from what's happened, and hope we know better because of what we've learned. When we last had a hearing in October, there was a pronounced disconnect between what the public health experts were telling the committee and the rhetoric of some of the committee members. Some members called for quarantines and travel bans that experts had determined would be harmful. Some claimed that the administration's protocols for screening and tracking travelers wouldn't work. Some even insinuated that immigrants with Ebola would soon be crossing the southern border, or that Ebola had mutated and become transmissible by air. This is hysterical rhetoric. It certainly induces a great deal of fear. But, Mr. Chairman, none of these things were true. After 2 cases were transmitted in Texas, the Centers for Disease Control acted quickly and decisively to acknowledge the gaps and revise protocols. It's learned from its experiences. It has now been 33 days since our last Ebola hearing, and since then, not one case of Ebola has been transmitted in the United States. Only one traveler since then, Dr. Craig Spencer, has unknowingly brought a case of Ebola into the country, and it appears that our healthcare system responded effectively. Dr. Spencer knew how to immediately report his symptoms, was quickly isolated, and safely transported to a hospital equipped to treat a patient with Ebola, and his close contacts were monitored. The health experts told us that our public health measures could protect the public from Ebola, and it turns out, Mr. Chairman, they were right. So it's good that we have a chance today to show some humility and acknowledge that the fears that were expressed openly in this hearing at our last meeting were not justified. As I said in that first hearing, we should have a sense of urgency about the epidemic in Africa. There's a lot of work to be done to stop the ongoing humanitarian crisis there, and we should view the appearance of Ebola cases in the United States as a wake-up call about the need for us to invest in public health preparedness at the federal, state, and local levels. President Obama is trying to address these challenges, and we should support those efforts. Because if we don't stop Ebola in Africa, it could travel to other places. It could spread. So we've got to control the epidemic where it's happening. On November 5, the President submitted a $6.2 billion emergency supplemental funding request to Congress to improve domestic and global health capacities in 3 critical areas: containment and treatment in West Africa, enhanced prevention, detection, and response to Ebola entering the U.S., and buttressing the U.S. public health system to respond rapidly and flexibly to all hazards in the future. It's critical, Mr. Chairman, that Congress support this request. There is ample precedent for an emergency public health supplemental appropriation of this magnitude. In November 2005, the Bush administration requested $7.1 billion in emergency supplemental funding to speed up the development of a vaccine and fund state, local, and federal preparedness. Ultimately, a bipartisan Congress provided President Bush with over $6 billion of this funding. In 2009, Congress provided the Obama administration with nearly $7 billion in emergency spending authority to combat H1N1 influenza virus. Congress did the right thing by making those investments. They saved lives, they enhanced our preparedness, and the Congress should do the right thing now. Thank you, Mr. Chairman. Yield back the balance of my time.
Gentleman yields back. I would now like to introduce the distinguished panel for today's hearing for the first panel. We're joined by Dr. Thomas Frieden, the Director of the Centers for Disease Control and Prevention, the Honorable Nicole Lurie, the Assistant Secretary for Preparedness and Response at the U.S. Department of Health and Human Services, Rear Admiral Boris Lushniak, the Acting United States Surgeon General, who also oversees the operations of the United States Public Health Services Commission Corps, comprised of approximately 6,000 uniformed health officers. I will now swear in the witnesses. You are aware that the committee is holding an investigative hearing, and when doing so has had the practice of taking testimony under oath. Do you have any objections to testifying under oath? All the witnesses say they do not. The chair then advises you that under the rules of the House and the rules of the committee, you are entitled to be advised by counsel. Do you desire to be advised by counsel during your testimony today? All the panel waves that. In that case, if you all please rise and raise your right hand, I'll swear you in. Do you swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth? Thank you. All the panelists have answered the affirmative. So now you are under oath and subject to the penalties set forth in Title 18, Section 1001 of the United States Code. You may now each give a 5-minute summary of your written statement. We'll start with you, Dr. Frieden.
Thank you very much, Chairman Murphy, Congresswoman Castor, full committee ranking member Waxman, and the other members of the committee. We appreciate the opportunity to come before you today and discuss what's happened in the past month since the last hearing. In the basics of Ebola, we continue to see the pattern that we have seen over the past 4 decades. In fact, in the more than 400 contacts that we've traced in the U.S., we have not seen spread outside of that one incident in Dallas in the healthcare setting among more than 2,000 travelers who've been monitored since arriving from West Africa. We've seen a series with fevers, but none with Ebola. So nothing changes the experience that we've had to date that Ebola spreads from someone who is sick, and it spreads through either unsafe caregiving in the home or healthcare facility, or in Africa, unsafe burial practices. Emergency funding is absolutely critical to protect Americans. It's critical to stop the outbreak at the source in Africa and to strengthen our protections here at home. Globally, in each of the 3 epicenter countries, we've seen rapid change, and flexibility is absolutely key to the response. In Liberia, we have seen promising developments in recent weeks, with some decrease in numbers, but still the number of new cases each week is in the many hundreds, and our ability to stop it is very challenging because it is now present in at least 13 of the 15 counties of Liberia, and our staff are now responding to as many as 1 new cluster or outbreak per day, compared over the past 4 decades with 1 cluster or outbreak per every year or 2. It's going to require a very intensive effort to trace each one of those chains of transmission and stop it so that we can end Ebola. In Sierra Leone, we're still seeing areas with widespread transmission, although some of the areas that have implemented the strategies we recommend have seen significant decreases as well. Guinea is in some ways the most interesting or concerning or instructive to look at because it shows what might happen in the future if we have progress in the first 2 countries. There is a challenge to trace each outbreak, each case, to reach each community and end the chains of transmission. That's why the emergency funding request outlines a comprehensive approach that's simple, straightforward, and focused, and approaches things by prevention, detection, response. three main categories. In West Africa, that prevention involves quarantine and screening, it involves infection control in hospitals and burials. It involves detection so that we find outbreaks promptly and strengthen surveillance and strengthen the ability of healthcare facilities and public health workers there to stop chains of transmission and response through core public health functions of contact tracing, training, infection control, public health education and outreach, and the use of rapid response teams. Globally, we're also seeing new threats with a cluster of cases in Mali. CDC has surged. We have 12 staff on the ground today in Mali. We were there before their first case, and they're now tracing more than 400 contacts, and we're helping them to do that and to test any who may have symptoms that could be Ebola. We also are aware that with the end of the rainy season, other parts of West Africa may experience an increase in travelers from the affected countries and may be at increased risk. The metaphor of a forest fire holds here, with the center burning still strongly, with a series of brush fires around the region, and with sparks that have the potential of igniting new sources and new challenges in the struggle against Ebola. Globally, the funding request also addresses the global health security aspect so that we can, with an emergency focus, stop the kind of vulnerabilities that keep other countries vulnerable and us vulnerable. Most of that, about 3/4 of the CDC component of that request, is to strengthen the warning systems, detection, laboratory networks, and others. There's also funds to respond rapidly and to prevent wherever possible. For the part of the funding request that covers the U.S., we have made progress. We're doing that through a series of levels, but each of those is going to require significant investments. Stopping it at the source in Africa, screening all travelers when they leave Africa, screening travelers when they arrive to the U.S., tracing each traveler for 21 days after they arrive here in all of the 50 states. The states have really stepped up and are doing an excellent job of that with CDC support and guidance, with excellent participation from Customs and Border Protection, which is now providing electronically collected data in just a question of hours to the states. We're seeing most states reaching 100% of travelers regularly, according to the information that they're reporting to us. So this is a relatively new program, but it's going smoothly. It is, however, working on borrowed dollars, and we will need funding from the emergency funding request to support this and other key measures of prevention, detection, and response within the U.S., public health systems, hospitals, laboratory networks, active monitoring, and more. Finally, I would emphasize that intensive public health action can stop Ebola. In Nigeria, they were able to surge and stop a cluster from spreading. Mali is now in the balance of whether it becomes the next Nigeria, having successfully contained a cluster, or the next Liberia or Sierra Leone with widespread transmission. This is a real warning that we must not let down our guard. The shifts and the changes in the epidemiology in Africa are just an emphasis of the need for a rapid and effective response, and emphasize that the only way to protect us in the U.S. is to stop it at the source and to build those systems both in Africa and in the U.S. that will find, stop, and prevent Ebola and other infectious disease threats. Thank you very much.
Thank you. Dr. Lurie, you're recognized for 5 minutes.
Great. Good afternoon, Chairman Murphy, Member Castor, and other members of the committee. I'm Dr. Nicole Lurie, the Assistant Secretary for Preparedness Response, or ASPR, at HHS. I appreciate the opportunity to talk to you today about actions that ASPR has taken to enhance our national preparedness and strengthen our resilience to public health threats. While it's essential that we continue to focus on controlling the Ebola outbreak in West Africa, we also have a critical responsibility to protect our country from this disease. Today, I'll highlight 3 areas in which ASPR's work is critical to our domestic response. First, the Biomedical Advanced Research and Development Authority, or BARDA, building on its previous successes in medical countermeasure development, is speeding the development, testing, and manufacture of Ebola vaccines and treatments. Second, the Hospital Preparedness Program has, since the beginning of this outbreak, been preparing hospitals and first responders to recognize and treat patients with suspected Ebola. And third, our federal resources and responders, whether the National Disaster Medical System, the Medical Reserve Corps, or the Public Health Service, stand ready to support a comprehensive response should it be needed in the coming months. BARDA, in coordination with other medical countermeasure partners, has a great track record in expanding the medical countermeasures pipeline and building needing infrastructure to do so. In addition to developing and procuring 12 products since Project BioShield's inception over a decade ago, BARDA's Centers for Innovation in Advanced Development and Manufacturing and its fill-finish manufacturing network are being used to produce, formulate, and fill vaccines and treatments for Ebola. Complementing our success in medical countermeasure development, ASPR's made great strides in U.S. healthcare system preparedness. HPP, or Hospital Preparedness Program investments, have fostered an increased level of preparedness throughout communities in this country, decreased reliance on federal aid following disasters. In the last several years, HPP awardees have demonstrated their ability to respond to and quickly recover from disasters, including tornadoes, floods, hurricanes, and fungal meningitis from contaminated steroids. Through HPP, ASPR is actively engaged in Ebola preparedness by developing and disseminating information, guidance, and checklists, and serving as a clearinghouse for lessons learned. Together with CDC, we've launched an aggressive outreach and education campaign that's now reached well over 360,000 people through webinars and national calls, including with public health officials, hospital executives, frontline healthcare workers, and others across the U.S. My office, along with the CDC, continues to recruit hospitals willing and able to provide definitive care to patients with Ebola in the United States. Concurrently, we're working with personal protective equipment manufacturers to coordinate supply and distribution, and are working with HPP-funded healthcare coalitions to collaboratively assess needs and share supplies across communities. The likelihood of a significant Ebola outbreak in the United States is quite small, but ASPR, HHS, and our interagency partners are, as you know, part of a coordinated whole-of-government response, a response that extends on the one hand to West Africa and on the other through state and local governments to hospitals and communities throughout the United States. As is typical for other emergencies and disasters, ASPR is responsible for public health and medical services and coordinates federal assistance to supplement state, local, territorial, and tribal resources in response to public health and medical care needs during emergencies. I'd like to close with an overview of the recent emergency funding request from the administration that includes $2.43 billion for HHS. ASPR's request supports two major components: BARDA's product development efforts and HPP's preparedness initiatives. Specifically, funding will support development of an Ebola vaccine and therapeutic candidates, clinical trials, and commercial-scale manufacturing. Funding will ensure that communities will be able to purchase additional personal protective equipment, that healthcare workers will receive additional training on patient detection, isolation, and infection control, and that we further build our preparedness for the future by ensuring that all states have facilities that can handle an infectious disease as serious as Ebola. Mr. Chairman and members of the committee, the top priority of my office is protecting the health of Americans. I can assure you that my team, the department, and our partners have been working and continue to work to ensure our nation is prepared to respond to threats like Ebola. I thank you for this opportunity to address these issues and welcome your questions.
Thank you. And now, Dr. Lushniak, you're recognized for 5 minutes.
Great. Thank you so much for this opportunity, Chairman Murphy, Member Castor, and members of the Oversight and Investigation Subcommittee. And thanks again for having us here to testify about the U.S. Public Health Service Commission Corps and its role in responding to the Ebola outbreak in West Africa. I'm here to provide information to you about what the Office of the Surgeon General, and specifically the United States Public Health Service Commission Corps, has contributed to this U.S. government-wide effort to stop the spread of Ebola virus disease, in essence where it began, in West Africa. The Commission Corps of the U.S. Public Health Service is made up of 6,700 uniformed officers. They're assigned to 26 different departments and agencies of the federal government, serving in 800 locations worldwide. I'm very proud of this group of officers. They're highly trained, mobile, medical and public health professionals operating under the departmental leadership of the Secretary of Health and Human Services and the day-to-day oversight of the Surgeon General and the Assistant Secretary for Health. Commission Corps is one of the 7 uniformed services of our nation, the only uniformed service of its kind in the world. It's an unarmed uniformed service dedicated to a public health mission and to medical care for underserved and vulnerable populations. The mission of the Corps is to protect, promote, and advance the health and safety of the nation. For 125 years, this is an anniversary year for us, Corps officers have been the government's dependable resource for health expertise and public health emergency services, working closely with the ASPR in times of war in the past and other national or international emergencies. Corps officers, like officers in other of our sister services, can be deployed at a moment's notice anywhere in the world to meet the needs of the President, the HHS, to address needs related to the well-being, security, and defense of the United States. We've had a long history of doing this, protecting the health and safety of the nation by addressing infectious disease overseas, smallpox as an example, polio, now Ebola. To ensure that we can meet the mandate to respond rapidly to urgent or emergency public health care needs around the globe, the Corps has established a tiered response system composed of 41 different general as well as specialty response teams. We've deployed in the past to events ranging from terrorist events, 9/11, the Boston bombings, anthrax, natural disasters, hurricanes, Katrina, Rita, Wilma, and Sandy, humanitarian assistance in Haiti, Indian Ocean tsunami, reconstruction and stabilization in Iraq and Afghanistan, public health crisis, H1N1, suicide clusters on Indian reservations, to hospital infrastructure rescue in the Mariana Islands. Over the past 10 years, the Corps has undertaken over 15,000 officer deployments in support of nearly 500 distinct missions and events. Corps officers now are currently operating in both the United States and in West Africa in clinical, epidemiological, education, management, liaison roles, supporting the Department of Health and Human Services, as well as working under the auspices of the Centers for Disease Control and Prevention. We have 900 officers stationed with the CDC. One critical element of the department's plan for combating the Ebola outbreak targets the ongoing need for healthcare personnel in the Ebola-affected countries. The United Nations estimated that 1,000 international healthcare workers would be needed on the ground in West Africa to bring the outbreak to an end. There's a wide consensus that in order to create conditions that will encourage both West African and international healthcare workers to contribute, yes, their time and skill to contain and ultimately end the Ebola outbreak, it is essential to establish a dedicated facility to provide high-level care for those healthcare workers should they become infected with the virus. In support of this objective, the Corps has deployed trained clinicians, physicians, nurses, behavioral health specialists, infection control officers, pharmacists, laboratory workers, administrative management personnel to Liberia to staff the Monrovia Medical Unit, the MMU. This is a U.S. government-funded 25-bed hospital that has been configured to function as an Ebola treatment unit. It provides advanced Ebola treatment to Liberian and international healthcare workers and to non-governmental organizations and UN personnel involved in the Ebola response. DOD, the State Department, USAID have provided invaluable support for this mission. It is being carried out with the full cooperation of the Liberian government and its Ministry of Health. Corps officers, the first team of the United States Public Health Service Commission Corps officers completed 1 week of advanced training in Alabama in October. They arrived in Liberia on October 27th. The full complement is staffing of 70 Corps officers, each of whom voluntarily accepted this assignment to provide direct care for Ebola patients. Additional training was completed in Liberia with support of NGOs such as Médecins Sans Frontières and the International Medical Corps. We have the equipment. We've gone through safety, clinical care, and management protocols. On November 12th, the MMU accepted its first patient, a Liberian healthcare worker. Today, the fourth patient is soon to be admitted. 4 overlapping teams of 70 officers will be scheduled for rotations of approximately 60-day deployments for an estimated 6 months of operations at this MMU. In conclusion, the safety of our personnel is our highest priority. We're making every effort to ensure that all Corps officers on the ground are working in an environment that will minimize any risk to their personal safety and security, following guidance from the CDC. To ensure the safety of our officers, their families, friends, co-workers, and the communities in which they live, work, and play, upon return, officers will undergo exposure risk assessment and, as indicated, be monitored by public health authorities. We look forward to welcoming home our personnel returning from this mission, providing them support and thanking them for the extraordinary efforts on behalf of the nation and peoples of West Africa. Thank you, Mr. Chairman, other members and members of the subcommittee, and I'll be happy to answer your questions at this time.
Thank you, Doctor. I'll now yield, authorize myself 5 minutes for questions for our panel. Dr. Frieden, so in the weeks that you've been dealing with this in the United States, can you highlight perhaps the top 3 things, lessons learned and modified from this that could give the public assurances that you're adapting as need be?
The most important principle that we are following in Ebola control is to find out as quickly as possible, as definitively as possible, what works, and then to implement that, both on the ground in West Africa and in the U.S. What we found is that treating Ebola in the U.S. is difficult. The 2 infections in Dallas were an indication of that, and we immediately moved to add a margin of safety to our guidelines for infection control and personal protective equipment. We also have put into place multiple levels of protection. Our top priority is protecting Americans, and we do that through control at the source in Africa, screening on exit, screening on entry, and the active monitoring program, as well as work with individual hospitals and health departments. We have something called rapid Ebola preparedness teams that have now visited more than 30 hospitals in more than 10 states to get those hospitals ready for the next Ebola case if one occurs. And actually a team had been to Bellevue before Dr. Spencer even became ill. Okay. So that rapid response is key, and rapid adjustment as we learn more about Ebola and Ebola in the U.S.
Okay, I want to get back to that hospitals issue in a minute here. Dr. Lurie, on August of 2014, under Section 564B of the Food and Drug Cosmetic Act, Secretary Burwell declared that circumstances exist justifying the authorization of emergency use of in vitro diagnostics for detection of the Ebola virus. Did you help advise Secretary Burwell of that declaration? Do you
Yes.
recall? Okay. So even though she declared Ebola to be an emergency for purposes of the FDA law, she has not declared Ebola to be a public health emergency under this. She's not made this declaration, even though the World Health Organization in August declared Ebola to be a public health emergency. Do you agree or disagree? Is this a public health emergency in the United States?
So in order for an investigational diagnostic test or drug to be used in the United States, the Secretary has the authority to declare that the conditions of a potential public health emergency exist. As I think Dr. Frieden and others have highlighted, fortunately, we've been very successful in the United States in detecting and controlling this disease. We have had 2 very unfortunate cases of transmission of this disease in the United States, but no others, and we believe that all of our efforts are quite effective in controlling the disease at this time.
We hope so, but fortunately is also an operative word there, and we want to make sure we're doing everything that we possibly can. On page 6 of your testimony, you mentioned you're responsible for coordinating the emergency support function number 8 response used in domestic or emergencies. Is that an operational responsibility that you have?
So my responsibilities are both policy advice, and we have operational response under ESFA, yes.
And that's been activated under the response to Ebola?
Yes, the Secretary's Operations Center is activated, and all components of ASPR are hard at work.
I'm just trying to clarify. So you're still the coordinator for emergency support function, or is that now Mr. Klain?
Mr. Klain is the Ebola coordinator for the country, yes.
Okay. So let me look at this. What data are you modeling, or have you done a data modeling to determine the number of cases we may anticipate in the United States? Have you done any of that data modeling?
So one of the things that we've done actually as a lesson learned from H1N1 is brought together modelers from all across the
But how
federal
many
government.
cases are you planning for in the United States? I mean,
So I think our models suggest that if we continue to be very aggressive about our exit screening from West Africa, our entry screening, tracking travelers for 21 days with active and direct active monitoring as we're doing, that we might expect a handful of cases in the United States, potentially in an unrecognized cluster, but that we don't anticipate that we're looking at a widespread outbreak.
okay, so but you're asking for $6.2 billion here, but you're saying you're expecting a handful of cases. And Senator Schumer just said, look, you owe New York City $20 million because we had to track all these people that came in contact with someone, but you don't believe in a policy of some kind of self-isolation, even though many of these NGOs do believe that in self-isolation. So there's a disconnect here. Expect a handful of cases, don't expect more, but asking for 50 hospitals to be prepared throughout the United States, but help me understand where the $6.2 billion.
Happy to. I don't think that there's really a disconnect at all. Our strategy for hospital preparedness looks first at being sure that beyond the biocontainment facilities at Emory in Nebraska and NIH, we have good, strong hospital capacity to recognize and treat through the entire course of illness an Ebola patient. First in the 5 cities where all passengers are being funneled. A next ring of hospitals is needed for geographic dispersion around the country to places where travelers are most likely to go, and that is a pretty good range of states now throughout the country. One of the things that we've learned, and you had asked Dr. Frieden about lessons learned, is that Mother Nature always has the upper hand. That means that we have to think about what's next after Ebola. Ebola has taught us that we really need high containment facilities. So far, our planning has been for pandemic preparedness on something that's airborne like pandemic flu. The containment needs, the infection control needs for something like Ebola are very, very different. So part of this emergency request is being able to meet our needs now by having a broad geographically dispersed network of hospitals able to treat Ebola, but it's also building toward the future because we don't know where the next cases are going to show up or the next kinds of travelers are going to show up, and we need to be prepared not only for today, but for the next decade and for the next century.
I'm way over my time. I have to recognize Ms. Castor for 5 minutes.
Thank you very much. On November 5th, the President requested $6.2 billion from Congress to enhance the U.S. Ebola response. The President's request focuses on stopping the outbreak at its source in West Africa. Dr. Frieden, in your testimony, you said you were focused in West Africa on prevention, detection, and response. Can you go into greater detail? The President's request designates $603 million to CDC for international response efforts. Discuss how these funds would specifically be used.
Thank you very much. Our approach would be on the prevention side to implement and strengthen quarantine and screening procedures so that those can be continued long-term and individuals with Ebola or potentially exposed to Ebola would be isolated, traced, and then promptly isolated if they become ill. Second, on the prevention side is infection control. This is an enormous challenge for West Africa because each of the facilities caring for patients needs to think of the possibility of Ebola in a country, in countries where malaria is endemic and where the symptoms of malaria and Ebola are not easily distinguishable. So that prevention is infection control, quarantine. On the detection side, laboratory and related services to find infections and find illnesses as soon as they occur. That relates to some of the U.S. funding, which would allow us to work with companies and other parts of the U.S. government to optimize some of the testing modalities. And then surveillance, so we're tracking what's going on with the detection and training of healthcare facilities to identify cases so they're found, isolated, cared for, and don't cause outbreaks. And then response, the core public health activities of contact tracing, training of healthcare workers, surveillance, public health education and outreach, rapid response teams, and support to ministries of health so that we don't need to be there long term. So we're training people to do the kind of prevention, detection, response that we're doing now.
What, if any, public health infrastructure was in place in West Africa
There were
beforehand?
very weak systems in place prior to this, public health or health care, really a shortage of trained workers. So part of our effort is to build up those systems so that they can continue that for many years to come.
Okay, and the budget request also would direct $1.98 billion to USAID, $112 million to the Department of Defense, and $127 million to the Department of State. Can you go through how funding to those agencies would assist in the broader effort?
I would have to refer you to them for the details, but in general, USAID is coordinating under the DART, or Disaster Assistance Response Team process, and they're enlisting many partners within countries, for example, for burial teams, which now exist all over Liberia and are rapidly and safely and respectfully collecting human remains of people who may have died from Ebola. We're also addressing some of the critically important areas of supporting development in areas like the Guinea Forest region, where there's a lot of resistance and some resentment, and services in that region are going to be very important in allowing us to get in and do Ebola control.
Okay. Dr. Lushniak, how would the supplemental funding assist the Public Health Service in their work in West Africa?
I think to a large extent, certainly running the Monrovia Medical Unit, it's supported by multiple agencies. Within the Department of Health and Human Services, certainly the supplement will assist us in that endeavor. DOD plays a key partnership role. They're really supplying us with other equipment, supplies, a lot of the logistical support on the ground. USAID, as mentioned by Dr. Frieden, is really out there also pushing ahead. And so, you know, from our perspective is that to have a continuous presence on the ground, and if we strongly believe that this mission is important, as I do, which is providing that medical care to healthcare workers, that the supplemental will assure a success of that mission.
Now, we've heard from Doctors Without Borders and other international organizations about the need for flexibility and adaptability in our response and in that budget request. How, Dr. Frieden, what measures are built into the supplemental budget request that would give us that flexibility and adaptability?
Well, first there is the contingency fund of $1.5 billion requested by the President, split essentially equally between the State Department / USAID and HHS, including CDC. That would be available, for example, if the disease breaks out in another part of Africa that we need to intensively surge to, or if we do have an effective vaccine, to implement a vaccine campaign will be quite challenging. Second, within the budget request, there is transfer authority, and that is extremely important so that we can adapt our response to what's needed. And third, within the CDC budget in particular, it would be a single budget line, so we would have flexibility within CDC to spend the resources specifically for Ebola control as they will be most efficient and most effective.
Thank you very much. I yield back.
Yields back now. Recognize Ms. Blackburn for 5 minutes.
Thank you, Mr. Chairman. Dr. Frieden, let me come to you. As I mentioned in my opening, keeping Americans safe, this is where our focus ought to be. And you said in your testimony, $621 million would be used to fortify domestic public health strategies. And you didn't mention the managing of waste products from patients with Ebola. And according to the Institutes of Medicine report from earlier this month, a patient with Ebola generates 30 to 40 times more medical waste than another patient. The report also states there is limited ability to handle Ebola medical waste in the U.S. So I've got a couple of questions. I can take a yes or no answer on these and be very happy with that. It'll help us move quickly. Will part of this funding, the $621 million, be directed to managing the medical waste products from treating Ebola patients, or will hospitals be expected to build on-site incinerators or autoclaves to decontaminate the waste?
Yes, funding will go to support hospitals to strengthen their waste management systems.
Okay. And then, do you have any plans to require sterilization of Category A waste, including Ebola waste, on site or as close as the source as possible?
CDC already provides guidelines for the management of waste potentially contaminated with the Ebola virus, and we would continue to recommend those same guidelines.
Does this include on-site?
Decontamination can be done either on-site or can safely be moved off-site.
Where is it going to go?
Where we are supporting hospitals to deal with Ebola, we would want that done on-site.
All right. Kind of got a little skirting the question there. Do you plan to procure and utilize mobile medical waste sterilizers?
That would be one option that could be considered.
Do you plan to do it?
It would depend on whether it made sense for the facility itself.
What about the waste in Africa, where we are supporting efforts?
In Africa, incineration is the method used for waste disposal in general.
Okay. On-site?
Generally on-site, yes.
On-site. Okay. Dr. Lurie, would like to come to you for a moment, if I may, please. The funding request includes $157 million for BARDA to support the manufacture of vaccines and synthetic therapeutics for use in clinical trials. Would this funding be slated to support manufacturing at one of the 3 Centers for Innovation in Advanced Development and Manufacturing that were established through previous funding for BARDA, or are you looking at other potential manufacturing partners?
Right now, funding is being used, and it would be anticipated to use to support both vaccine development, vaccine manufacturing, and fill and finish vaccine capacity. Also, the continued capacity and fill and finish of therapeutic products such as ZMapp. We are actively engaged both with the Centers for Innovation, Advanced Development, and Manufacturing, and with the fill-finish network components to look at the role that they can play.
So you are engaging other partners,
We are engaging the range of
private
partners.
sector?
Yes. We're
Okay.
engaging the range of partners that it's going to take to get us vaccine and therapeutics.
Okay, well, we had read Secretary Burwell's testimony last week, as I'm sure you have, from the Senate Appropriates Committee, and it seems as if the funding for BARDA would go to manufacturing quantities of those products that undergo successful early development at NIH. And we know there are several private companies who have committed significant resources to develop treatments or vaccines for Ebola, and we want to make certain that those companies are involved in processes going forward. So it is my understanding you're saying you plan to include them and invite them.
So any company with a promising product is always welcomed into BARDA, and we have a system to sit and talk with them, determine whether they have promising candidates, and for them to submit proposals that get evaluated. What I can tell you in this sense is that it's generally NIH's role to support the early development of products. It's BARDA's role to support the advanced development of products, and BARDA is and will continue to support the advanced development of both vaccines and therapeutics, and to get them scaled up so that if they work, they can be used in a mass vaccination campaign or in therapies.
Thank you. I yield back.
Gentleman yields back. Now recognize Mr. Waxman for 5 minutes.
Thank you, Mr. Chairman. Dr. Frieden, you and a number of other experts have said numerous times, and you said it here today, the key to protecting Americans from Ebola is stopping the disease at its source in West Africa. Can you explain the approach being taken in West Africa to contain the spread of this disease?
In brief, to identify patients who have Ebola promptly, get them isolated and cared for safely, and in the event that individuals die, have them buried respectfully and safely without spreading disease, to turn off those two main drivers of the infection, unsafe care and unsafe burial. That's what we've done till date in every outbreak until now, but the size, scale, and speed required now remains daunting, with instead of dozens or a handful of cases, still hundreds or thousands of cases to deal with.
So would you say the approach is working, but the epidemic is moving too quickly to keep up with the amount of cases?
I think the decrease in cases in some areas within West Africa is proof of principle that the approach works, but we're still very far from the finish line.
Mm-hmm. Well, what are the consequences of failure in Africa?
If we're not able to stop the Ebola epidemic in West Africa, the risks are very high that it would spread to other parts of Africa because of travel within Africa. If that were to occur, then it could be a matter of many years before we would be able to control it, and the threat to the U.S. and other countries would be proportionately greater.
Well, some people say if that's the concern, why don't we just seal off Africa, not let people travel here from Africa? Would that solve the problem?
From the standpoint of public health, we look at, first and foremost, protecting Americans from risk, protecting Americans from threats. And currently we have systems in place that trace each person who leaves one of the 3 affected countries, each person who arrives to the U.S. and follows them for 21 days. We've already had people develop fever who've called up the health department with the 24/7 number that we provided to them and have been safely transported and safely cared for and have ruled out for Ebola. But those systems rely on knowing where people are coming from and how they're getting here.
The President's asked for more money in the supplemental budget. Big portion of that's going to go to our efforts in Africa to try to stop and contain this disease. But some of that money is going to be used right here in the United States to enhance U.S. government response to the Ebola outbreak. The request includes $621 million for CDC for domestic Ebola response. Can you give a brief summary of what programs and initiatives are covered by this funding?
Thank you. These would allow us to work with states so that all travelers are traced on a daily basis, and if they become ill, are promptly and safely taken to a facility that's ready to care for them. They would result in safer hospitals, not just from Ebola, but also other infectious disease threats. There is a small research component that would allow us to implement a vaccine trial, probably in Sierra Leone in the coming months, to determine whether vaccination works. Other research would help us with rapid diagnostics so that we could detect more rapidly if someone became ill. We also would support all jurisdictions to be better prepared for Ebola and other infectious disease threats, have safer hospitals, more rapid response, and work very closely with the state, between the state and the hospital systems within the state on infection control generally, Ebola and other deadly threats, specifically working very closely with the funding for ASPR and other parts of hospital preparedness.
Well, it seems to me that it shouldn't be partisan in any way for us to give the grant of money the President's requested to deal with this terrible epidemic in Africa and to protect Americans as well. And the request is quite balanced in helping us deal with the situation as we now have it. And in past times, we've always had bipartisan support. But talking about here in the United States, what if we had a pandemic flu? That would certainly be a lot more dangerous because of how fast it could spread. Would these funds help us to deal with that? And secondly, are we prepared for a pandemic flu? Do we have a stockpile of the medications? And are we ready? As you said, we don't know what will come next, but if that happened, are we ready for it?
We always work to be better prepared today than we were yesterday and better prepared tomorrow than we are today. A pandemic of influenza remains one of the most concerning possibilities in all of infectious disease threats. The funding in the emergency supplemental, the emergency funding request would assist this country, health departments, hospitals, the healthcare system, the public, to be better prepared for Ebola and other infectious disease threats, such as the pandemic influenza, yes.
Thank you. Thank you, Mr. Chairman.
You now recognize Dr. Burgess for 5 minutes.
Thank you, Mr. Chairman. Before I start my questioning, I would like to submit for the record this document from the American Hospital Association for the record for today's hearing.
Without objection.
And Dr. Frieden, the administration's additional funding request states that money will go toward 50 Ebola treatment centers throughout the United States. Some states, Texas, has already started to designate sites on their own. So will state-designated centers be included in that number 50, or will that be in addition to?
I'll comment, and Dr. Lurie may want to continue. Our approach is to strengthen the statewide systems. It would be the states that would be responsible for, in collaboration and communication with hospitals, determining which hospitals would be used. But what we've asked each state to do is 4 things related to the active monitoring program. First, establish the program including information flow from the state health department to local health departments. Second, establish a 24/7 hotline for any traveler or anyone who thinks they may have Ebola to call so that they can be safely managed. Third, establish safe transport between wherever that person calls from and the facility that the state has decided will be the facility to assess them or treat them for Ebola. And the fourth is to work with their hospitals to identify facilities that are able to do that assessment and treatment.
Let me just add, it would be great if you had a 24/7 hotline for hospitals when they find that that suspected patient is on their doorstep at 3 o'clock in the morning. But Dr. Lurie, let me ask you the same question. The 50 centers that are designated in the President's budget request, is that in addition to the state-designated centers? Or would those 2 state-designated centers in Texas fall under the purview of the 50 centers that President Obama is describing?
So as Dr. Frieden said, our process and our plans have been to work through the states to identify facilities. The process works basically
so make it really simple. The two centers that Governor Perry has designated the state of Texas, do those fall under the parameters of what the President's budget request as it exists today?
The funding will go to the states, and the states, in conjunction with the hospitals, will determine which of the hospitals will serve as infectious disease containment centers or the Ebola treatment centers.
I guess that's as close as I'm going to get to an answer. Let me just ask you a question. Dr. Leary, do you report to Ron Klain? Is that someone now who is in the hierarchical reporting structure that you have? Is he a person to whom you report?
I report to the secretary, and I interface with Mr. Klain on a very regular basis.
Well, in your testimony, you say that under the National Response Framework, my office, your office, is responsible for coordinating the Emergency Support Function Number 8 response, which is listed here. So where does Mr. Klain's responsibility fall in the Emergency Support Function Number 8?
So during different kinds of events in the United States, whether they're national disasters or whether they're other kinds of emergencies, either FEMA is activated, and as it is for hurricanes and floods, and I know we've worked together in Texas on a number of those things, FEMA is activated, and Emergency Support Function Number 8, Public Health and Medical Services, are activated under that framework. In other kinds of emergencies...
Let me just interrupt you for a minute. And that is under the coordination and control of Secretary Burwell, is that correct?
Emergency Support Function 8, yes.
Where, does Mr. Klain have a role with Emergency Support Function
So
8?
in this situation, we've not had a declared national emergency. FEMA's not been activated. However, we do have obviously a very serious situation in the United States, and Mr. Klain is the national coordinator for the country.
Let me interrupt you for a moment because my time is going to run out. So I guess it's not fair to say that you have an emergency plan, but do you have a very serious situation plan that you're working under?
We are doing very aggressive planning, both for what we have in the here and now and for all the what-ifs. And we work across HHS and with all of the rest of the components of the federal government on that what-if planning.
And I'm going to assume that you will be able to make the details of that plan available to the committee staff?
It is continues to be in draft. We continue to work through the what-ifs with our partners across government. Yes.
Well, yes was the answer. You will.
Yes,
you will.
when we have the rest of the plan together, it's something that's a whole of government plan. It's not an HHS plan.
Okay, well, it's time. And then, Dr. Frieden, I just have to ask you, I mean, we had 2 nurses that worked at Presbyterian Hospital that were infected. I'm just got to tell you, when you get that call at 2 o'clock on a Sunday morning that a nurse has been infected, you don't have a lot of confidence that things are working the way they were outlined. Do you have any insight as to how those 2 nurses became infected and what we can do to protect our healthcare workers going forward?
While we don't know definitively how those infections occurred, the evidence points to them having been infected in the first 48 hours after Mr. Duncan was admitted to the hospital before his diagnosis was confirmed. That is consistent with the period of time between onset of symptoms and exposure. It's also consistent with the observations of the team from CDC that arrived on the day of diagnosis of Mr. Duncan and found that in the intense efforts of the healthcare workers to protect themselves, they may have inadvertently increased their risk by some of the ways that they were working with personal protective equipment. And that's why CDC immediately strengthened the margin of safety and established new guidelines for personal protective equipment that include as 2 critical components practicing repeatedly so that healthcare workers have comfort with the equipment they'll be using and direct observation of every step of putting on and taking off the protective equipment.
And this just underscores why it is so important to have those treatment centers available around the country, because I can just tell you the average ICU is not set up for that type of activity of the donning and doffing of the protective equipment. I also have a problem with the time frame that you just enumerated because Mr. Duncan's family never became symptomatic, and I would suspect it's later in the course when he was throwing off really massive amounts of viral particles where the greater risk for exposure to those healthcare workers occurred. But I'm sure you and I will have future discussions about that. I'll yield back.
Yeah, and just to clarify, Dr. Fried, during that time, Mr. Duncan, at what point did he actually disclose that he had been in Western Africa and been exposed to Ebola?
My understanding is that he disclosed that he was from West Africa on the earlier emergency department visit, which started on the 25th of September. He was admitted on the 28th of September.
Okay, thank you. Now, Mr. Green's recognized for 5 minutes.
Thank you, Mr. Chairman. To follow up my colleague from Texas, I know our state has designated 2 locations, but about 2 months ago, I was at the Texas Medical Center in Houston, and there was some interest in it on trying to do that too, and that may not be one of the 2 locations that the governor has designated. But I have a question later for Dr. Gold from University of Nebraska, how it was unique that University of Nebraska created that facility there and how it happened. But let me get to my questions for you, Dr. Friedman. What is the process and timeline for updating and communicating changes to protocols to local healthcare providers? Because we know, and there was an issue about that last month, is what is the process or have the processes changed at the CDC to where, from what we did, say, in October?
With respect to CDC guidelines, we use the latest data, information, and experience to develop guidelines. We consult widely with affected parties to get input, and then as soon as we have a clear set of guidelines that we communicate, we then disseminate those through a wide variety of networks.
What we've learned from the failure is isolation and personnel protection from the experience at Texas Presbyterian. How are these lessons being shared with other hospitals so we can avoid the same errors? And again, the feeling that somebody shows up at 3 o'clock at one of my not-for-profit hospitals in an urban Houston, how are they going to be able to deal with something like that?
We're dealing with this from both sides of the equation. First, the patient side. And what we've done is for every single person coming from West Africa, they're greeted, they're asked detailed questions, their temperature is taken, and they're provided a care kit that includes a thermometer, a log for taking their temperature, a wallet card with a 24/7 number to call. And we've already had multiple times in the past few weeks, individuals take their temperature, find that they had an elevated temperature, call that number, be safely transported to and safely cared for in a facility. They all ruled out for Ebola, but the system worked in those cases. We can't guarantee that it will work in every case, and that's why we're working very intensively with hospitals throughout the U.S. to prepare them for the possibility that they could have someone with Ebola. We've released guidelines. We've done, in conjunction with the rest of HHS, training sessions. We've had hospital visits by rapid Ebola preparedness teams to more than 30 hospitals, more than 10 states, and we'll continue to work intensively with the healthcare system so that they're increasingly well prepared to address a possible case of Ebola.
The CDC is not a regulatory agency. How can you provide clarity over the CDC's authority and responsibilities in setting and enforcement of these protocols? Do you have any authority enforcement over hospital settings?
CDC provides guidelines and information. We provide tools and feedback to facilities. We do not regulate in this area. That would be up to other entities within the federal and state governments.
Okay, thank you. Dr. Lori, without a commercial market, the development and manufacture of many medical countermeasures like those against Ebola and other infectious diseases require public-private partnership. Congress recognized this when it created the Project BioShield, successfully driving innovation by providing a stable source of funding so that a reliable market for medical countermeasures was in place. Dr. Lori, as you know, the development of medical countermeasure for a biological threat agent can take a decade or more and often $1 billion to develop. The U.S. government research on Ebola countermeasures goes back a decade, but the level of investment and urgency was not enough to prepare us for the current situation. Can you provide a dollar figure on how much investment you perceive is needed for Ebola vaccines and drugs to allow us to get to the chance of successfully developing a product?
So I'm sorry, I didn't hear the last part of the question. Could I provide a dollar figure?
Can you provide us a dollar amount, estimated dollar amount on how much investment you perceive is needed for Ebola vaccines and drugs to allow us the best chance of successfully developing these products? Again, like I said earlier, our research program in Ebola has been going on for a decade. Is there any resources you could use that would, and how much would we need to do to get that the drugs?
Absolutely. And in fact, one of the reasons that we now have 2 vaccines that are finishing safety trials is because of prior investments made across the U.S. government in trying to develop an Ebola vaccine and also with Ebola therapeutics. As you know or may know right now, those vaccines are finishing those early trials, and thanks to money that was provided in the CR, we've been able to accelerate some of the work both on vaccines and therapeutics. Whether these vaccines work is going to be something that we're going to learn over the next coming months with the trial in West Africa. At the same time, we have now gone ahead and invested in the advanced development of 3 other vaccine candidates and additional ways of scaling up and making the therapeutics, so that we never put all of our eggs in one basket. We always want to do better, and we'll continue to do that through the investments. We've really appreciated the support from Congress, from BARDA and Project BioShield in this regard.
Okay. Thank you, Mr. Chairman. I know I'm out of time, and I want to thank our colleague, our panel today, and I'm waiting for our second panel.
Gentleman yields back now. Recognize Chairman Emeritus Mr. Barton, 5 minutes.
Thank you, Mr. Chairman. And, Congressman Green didn't want to brag, but he has a family member who's very active in this up at Nebraska, and we appreciate his family being on the front lines, and I'm sure I think it's your daughter, isn't it your daughter that works up there? So we want to welcome our witnesses, and on the second panel, Dr. Lakey from Texas, we're glad that you're here. My first question I'm going to ask the Rear Admiral, the Acting Surgeon General. I believe that we should treat this first and foremost as a health issue and not as any other kind of an issue. And it puzzles me that we have not really effectively put in a travel ban from West Africa. I know we've alerted people and all of that, but when we had the hearing down in Dallas, Fort Worth at the airport, the answer we got was because we need to send personnel over there, we don't want to prevent people traveling to here. As a pure public health official, as a Surgeon General, why would we not put in a true quarantine and just flat prevent any travel from West Africa?
Well, certainly, as stated, and I have a strong belief in this, is that currently as we have it, the idea of having a travel ban prohibits all travel. To some extent, there is that sense of travel of healthcare workers to Western Africa, and I stated earlier, the real resolution to this issue is solving the problem in West Africa. But at the same time, instilling a travel ban has a total loss of control of who enters and how they enter this country. And as Dr. Frieden stated earlier, we've set up these systems. The systems that are in place right now allow us to know where people are coming from. It allows us to track them appropriately through the public health endeavors at the state and local level, and to be able ultimately to follow them appropriately, to be able to intervene if symptoms appear, and then be able to direct them, detect them appropriately, and to instill the right response for that. So right now, as the system works, as the Acting Surgeon General, I find that the appropriate course of action.
Okay. Well, it puzzles me. If we were to have a health outbreak, tuberculosis or something, there wouldn't be any question in my area that the Texas Department of Health would put a true quarantine in place. And I understand some of the external reasons, but if you're trying to contain an epidemic, it's old-fashioned, but an absolute ban and absolute quarantine does work. When I asked Dr. Frieden, there's been some concern that perhaps we don't really know how this disease is transmitted, and unless something's come out very recently, some of the individuals in Texas that were potentially infected and put on the watch list had no apparent means of transmission, yet they were symptomatic. Is your agency conducting any research right now to see if perhaps there might be more methods of transmission than we think exist today?
We do a broad variety of research specifically on Ebola and on the public health spread and epidemiology of it. The 2 infections that occurred in this country of the 2 nurses at Texas Presbyterian are infections that occurred at a time when Mr. Duncan was highly infectious. He had production of large quantities of highly infectious material through diarrhea and vomiting, and that would be our leading explanation of how they're most likely to have been infected, although we do not know for certain. We describe what we see, and what we see in Africa is that people become infected by caring for or touching someone who who's either very ill with Ebola or who has died from it. And when we analyze the amount of virus in a patient's body, it goes from undetectable when they're exposed but not ill to very small quantities when they first become ill. And then as they get sicker, the quantities increase enormously. And if someone dies from Ebola, the quantities are quite large of infectious material.
As a medical professional yourself, what's your confidence level that there is no other method of transmission than we know about today? In other words, are you 100% certain that there's no other way? Are you 70% certain?
In medicine, we say never say never. So I would not be surprised if there were unusual occurrences of spread from a variety of ways. But the way it is spreading by and large in Africa, the way it's spread here, and the risk to people here are by those two main mechanisms of touching body fluids of someone very ill. I will mention that one of the things that we looked at in our new guidance in the U.S. is what is done in U.S. healthcare facilities. Very different from what's done in African healthcare facilities. There's more hands-on nursing care. There may be artificial respiration or ventilation of someone, and that may generate infectious particles, and that's why we've strengthened the level of respiratory protection in our personal protective equipment guidelines.
Thank you, Mr. Chairman. My time's expired.
Thank you. Now recognize Mr. Braley for 5 minutes.
Thank you, Mr. Chairman. And Dr. Lurie, I want to clarify some of the questions that Congresswoman Blackburn was asking you earlier, because at our first hearing on October 16th, Dr. Fauci was kind enough to present us with some materials and walked us through them, including this product development pipeline, which I think you described in your testimony, talking about early concept and product development being the province of NIH, the advanced development being the province of BARDA, then commercial manufacturing by the industry itself, and then regulatory review. And then the next page in his presentation dealt with Ebola therapeutics in development. It's my understanding these are the treatments that are being developed for the symptoms of the Ebola virus, as opposed to a vaccine that would hopefully prevent the virus from spreading, correct? And then he had a slide that talked about the Ebola vaccines that were in or approaching phase 1 trial. The first one is the GlaxoSmithKline. The second one was New Link Genetics, which is based in Ames, Iowa. And I asked him questions about that at the time, and I also questioned Dr. Robinson. In this particular slide, it appeared there were only 2 companies, GlaxoSmithKline and New Link, that actually had phase 1 trials ongoing. Has there been any change to that since our hearing on October 16th?
Since the hearing on October 16th, the phase 1 trials have been underway. They are almost completed. We're analyzing the data, and I think we're all very optimistic that we'll be able to start the next phase of the trial, which will be a randomized controlled trial with both of those vaccines in West Africa.
This slide indicated that there was a third company, Crucell, but they were not expected to engage in phase 1 trials until the fall of 2015, which is a substantial ways away from where we are today.
There are other potential vaccine candidates in the pipeline. We're supporting some of those, but you're right. They are behind this timeline, and we are right now focused on trying to figure out if these vaccines are safe and effective, and if they are, get them into use to control the epidemic in West Africa. And so part of the emergency funding request will be $157 million for BARDA to continue to accelerate the development and manufacturing of vaccines and therapeutics for this outbreak.
And my understanding from talking to the folks at New Link Genetics is that these clinical trials that have been ongoing at Walter Reed and the National Institute of Allergy and Infectious Disease have been progressing well, that there has been good rapport between the oversight agencies and the company involved, and that there is continuing to be ongoing interactions with the Department of Defense sponsors as well, which would be the Defense Threat Reduction Agency and the Joint Vaccine Acquisition Program. Is that your understanding as well?
That is, in fact, every week, either once a week or twice a week, I run a call with all of the parties, NIH, CDC, FDA, BARDA, the DoD components, so that we are all joined at the hip through every step of the process. We know what's going on. We share information. We know what to anticipate. FDA has been a really key partner in this as well, because, in fact, it's their regulatory authority. that is going to determine, ultimately what moves forward and what doesn't, as well as obviously the results from the trial. I never thought I would find myself in this situation, but I'm saying we're all racing to catch up with FDA. It's a great situation to be in, but everybody's working extremely effectively together.
Great. Dr. Lushniak, Mr. Barton asked you a question about trying to contain an epidemic with an absolute quarantine. Is there an Ebola epidemic in the United States right now?
There is not an Ebola epidemic in the United States. The epidemic is, at this point in time, limited to Western Africa, and once again, that's why we're trying to contain it there.
And one of the things that we've talked about during these hearings is the importance of focusing on facts and science and medicine. In 1900, the two leading causes of death in this country were influenza, pneumonia, and tuberculosis, and neither one of those are a leading cause of death anymore because of the response of science and medicine and public health. So when you look at the fact that in 2012 there were 35 million people living with HIV around the globe, and that there are currently 14,000 to 15,000 diagnosed cases of Ebola, it seems to me that with the proper application of science and medicine and public health, we should be able to manage this crisis if we devote the necessary resources on a global basis. Would you agree with that?
Yes, I agree.
Thank you.
Mr. Scalise, you're recognized for 5 minutes.
Thank you, Mr. Chairman, and I appreciate you having this second hearing on Ebola, and I want to thank the panelists for coming. Would have liked to seen Mr. Klein be a part of this. I know the committee's made a request for him to appear. I'm not sure what if he's the Ebola czar, what his real role is, if he's not going to be coming before the committees that hold the administration accountable and have some transparency to talk about it. I hope he's not planning just being a propaganda czar, that he would actually be focused on working with us to get solutions to this. But I do want to thank the panelists that are here. Dr. Frieden, the last time that you were here, we had talked about a number of things. One of those was the comments that we heard from Samaritan's Purse. It's a group that's going to be on the second panel. I'm not sure if you saw their testimony. One of the things I'd asked you about were some of their comments they'd previously made that they were blown off, in essence, by your agency, and I'd asked if you knew about that. You said you'd heard about it, hadn't looked into it. Have you looked into it to see what's going on there? Are some people in your agency that maybe weren't taking advice from groups like that seriously enough? Can you follow up on that last conversation we had about those complaints that Samaritan's Purse made?
I'm not familiar with suggestions or complaints or concerns that have been raised with us that we have not addressed. I've received one communication from Samaritan's Purse, a very helpful communication about safety of our own staff, and we immediately acted upon that.
At the last hearing, I had read to you some comments that they had made. One was a quote where they said, "They kind of blew me off," and then they made some other comments that implied that maybe they weren't being taken seriously by your agency. I never said it was you, but I asked if you had looked into that or heard about it. Your quote was, "I don't know that occurred," and then you said you would look into it. And so that's why I was asking if you had looked into it since our last hearing. They make some other claims in their testimony that they're going to give today. Quote, this is some of the comments that they make. "Many public health experts are telling us that we know the disease, how to fight it, and how to stop it. Everything we have seen in this current outbreak, however, suggests that we do not know the science of Ebola as well as we think we do." Do you agree with that statement or have any response?
I think we're certainly still learning about Ebola and what is the best way to fight it. That's a critical component of our activities. It's a critical component of the emergency funding request as well.
All right. They also say the disease has been underestimated from day one. Do you know if that maybe was going on? Is it still going on? Do you think that it was being underestimated, maybe now not being underestimated to that level?
CDC publications estimated the degree of underreporting could be as high as a factor of 2.5 back over the summer. Our sense is that that is likely to have decreased in some areas. Fundamentally, the more out of control it gets, the more systems don't keep up with it, including systems to track the disease. And if patients don't have a place to come in, they're much less likely to be counted and accounted for.
Is there any new conversation that you've had with the administration, especially the White House, about what's been talked about by a lot of our members of having some sort of travel ban, or at least a holding period for folks who are over there having direct contact with people in West Africa that have Ebola and then come back into the United States to at least have some longer period to look at them to make sure they don't come back with Ebola. Have y'all had those conversations since we last met?
Yes, we have. My top priority as CDC director is to protect the American people. And I have said, and others have said, that we'll look at anything that will reduce the risk to Americans. What we don't want to do is inadvertently make it worse by, for example, interfering with the system that we have now, which allows us to track people when they leave, when they arrive, and for 21 days after. We're at 100% follow-up in most states for people who've come into this country. And that kind of system, if we don't have it, could result paradoxically in a greater rather than a lower degree of risk.
Well, let me ask you about Ron Klein, because again, we did ask that he come and participate in this. He has been designated by President Obama as the Ebola czar. Have you had contact with him about strategy, about how to deal with this?
Mr. Klein is the Ebola response coordinator. I have frequent contact with him. He coordinates the response of different parts of the U.S. government. He advances.
Have the two of y'all had any disagreements on how to approach this?
No, we have not.
None. If you did, who would ultimately make the decision if you felt we ought to go this way and he felt the administration ought to go that way? Is there a hierarchy right now?
Mr. Klein has been very clear that technical decisions, scientific decisions that are the purview of CDC are made by CDC.
All right, I'm out of time, and I appreciate your question, your answers, and thanks for coming again. Thanks. Yield back.
Thank you, gentleman. Yields back. Now recognize Mr. Tonko for 5 minutes.
Thank you, Mr. Chair, and thank you to our panelists for your dedicated work on this issue and for appearing before us today. We've heard time and time again that the key to keeping the United States safe is to eradicate the virus at its source. And while we've had early indications of momentum begin to emerge in Liberia, it seems as if the situations in Sierra Leone and Guinea are not showing the same promising signs. So, Dr. Frieden, in your opinion, do we have the resources deployed in these countries to turn the tide of Ebola? And if not, what additional resources are needed?
The emergency funding request is essential to our ability to both protect ourselves here at home and stop Ebola at the source, and also to prevent the next Ebola. There are too many blind spots, too many weak links in places in Africa and elsewhere where we have large amounts of travel, where we have animal-human interface, and we have large numbers of people. And that's why all three of the CDC components of this and all of the components of the emergency funding request are so important. The three CDC-related components are domestic preparedness, stopping Ebola in West Africa, and preventing the next Ebola through the global health security work.
Thank you. And I know that as of a few weeks ago, the count on the ground through PFC2C is 4 individuals from CDC in Guinea. While I know that France is taking the lead on Ebola response in this country, does the United States need to take a more leadership active role, or does it have the capacity to do so?
Excuse me. For the CDC-specific response, we provide a comprehensive public health approach in each of the affected countries. As of today, we have approximately 175 staff on the ground in West Africa. We actually have the most staff in Sierra Leone, where the needs are greatest. We also have more than 20 staff, or roughly 20 staff, in Guinea, but there are additional needs for staff in Guinea, and we've worked very hard with the African Union and with other partners to get French-speaking staff there. With the cluster in Mali, we now have 12 staff as of today in Mali dealing with that cluster and trying to stop it at the source.
And what about engaging a more international impact? How does the international community get engaged to devote its additional resources to this world health crisis?
There's been a very robust global response. My understanding is that currently contributions from other countries total more than $1 billion. The World Bank has been very proactive and effective. Also, we've seen the UK stepping up in Sierra Leone, and increasingly French and EU support to Guinea and other areas.
Mm-hmm. And Dr. Frieden, we keep hearing that there is a great need for medical volunteers to travel to West Africa. Do you have a sense of how many medical personnel are needed, and how would one get involved?
For American healthcare workers, the U.S. Agency for International Development, USAID, maintains a website. On that website, you can go and volunteer. We ask that Americans who want to be involved do so through another organization. So they're not going as individuals, but as part of an organized approach. And there's a broad need for assistance, including French-speaking assistance, including not just clinical care, but also epidemiologic interventions and public health measures.
So that's reaching out for volunteers. Is there any activism in terms of encouraging or recruiting personnel?
There's been quite a bit of effort by individual organizations within the U.S. as well as USAID. For our own part at CDC, we're looking at epidemiologists among not only our own staff, but former staff and people from the broader public health community who may be able to deploy. What we're finding is that this is going to be a long road. It's going to take many months, and so we need people who are willing to go not just for a week or a month, but for several months or longer, so that they can get that maximal effectiveness by being there. Although for the clinical interventions, where you're working in the isolation unit, we like to limit that to 4 to 6 weeks at most, so people can be well rested and minimize their chance of taking a risk that might result in infection.
Mm-hmm. And Dr. Frieden, we've heard anecdotally that hospitals across the country are having difficulty sourcing PPE. What is the CDC's role in facilitating the PPE supply chain and the allocation of these PPEs? And could the U.S. ramp up manufacturing of PPE needed to contain a domestic Ebola outbreak?
Dr. Lurie and Asper can address some of the manufacturing aspects. From the CDC perspective, we operate the Strategic National Stockpile. We've already stockpiled PPE to enable us to rapidly, within hours, deploy PPE to any hospital within the U.S. That's one of the components of the emergency funding request. But in addition, we've conducted what are called REP, or Rapid Emergency Preparedness visits, to more than 30 hospitals in more than 10 states. One component of that is addressing whether they have sufficient PPE. We've prioritized hospitals near airports, where those 5 airports where people come in, or where a large number of the African diaspora live, and we already have identified dozens of hospitals which are prepared in terms of their procedures and have ample PPE, but we understand that not every hospital in America can get every amount of personal protective equipment they want, and that's why Dr. Lurie's office has been working closely with manufacturers to both ramp up manufacture and prioritize those facilities most likely to need it, and we've been working with the SNS, or Strategic National Stockpile, to have PPE that we could deploy very quickly to hospitals around the country.
Thank you. I yield back, Mr.
Thank you. Mr. Harper is recognized for 5 minutes.
Thank you, Mr. Chairman, and thanks to each of you for being here and shedding some light on this evolving situation. And both you, Dr. Frieden, and you, Dr. Lurie, have told us that this emergency funding request supports non-immediate, non-Ebola specific funding is part of this. Not all of this would be directly for Ebola, would it?
No, I would disagree with that.
Okay.
The request is divided into 2 components: immediate and contingency.
All right.
All of it is addressing Ebola. It addresses it with respect to the CDC in 3 ways: domestic preparedness for Ebola and other infectious disease threats, because we think it would be most responsible to not only address Ebola, but also strengthen our system more broadly, stopping Ebola in West Africa, and addressing the risk that there will be another Ebola outbreak, spread of Ebola, or spread of a disease like Ebola elsewhere in the world through the global health security component.
Could not some of that be handled through the traditional appropriations process?
The situation is urgent with respect to Ebola. CDC models indicate that for each month of delay in control, the size of the outbreak can triple. So as a CDC director, I'm not going to address the mechanism, but I can say that the need for urgent funds with flexibility in those use of funds is crucial.
If I could, Dr. Frieden, ask you, you had commented earlier that 2,000 travelers have been monitored or are being monitored. How many are being monitored this moment? What is that number?
It's roughly 1,500. The number of travelers entering is lower than it had been previously.
Who maintains that list of who's being monitored?
So every person who comes through goes through the CBP process, Customs and Border Protection. We work in conjunction with CBP. That information is collected from the travelers, and within hours we provide it to each state health department. We then monitor with state health departments and resolve challenges if someone's hard to find or moves from state to state.
Okay. Are there any that were being monitored that you've lost track of?
A tiny fraction, actually less than 1%, have been monitored and then not found. Some of those were later found to have left the country to go back on travel or otherwise. The program is relatively new. It only started less than a month ago, about a month ago, and what we're finding is an excellent participation from the states and the travelers, but it is challenging, and one of the things that would be supported in the emergency funding request are funds for state health departments to operate those systems.
And of those that are being monitored, how many are being told to seek medical attention?
We do expect that there will be a steady stream of people with symptoms. If you just take a set of 1,500 adults, you're going to expect some to have flu, some to have other illnesses, and from West Africa, more, because malaria is common. So, for example, in the past several weeks, there have been 4 individuals who used the care kit, check and report Ebola, that we provided to them at the airport, took their temperature, found that it was elevated, called the number that they were provided with, were safely transported to a healthcare facility and safely cared for there. They all ruled out for Ebola, but they were cared for in a safe way.
All right, let me ask for just a moment. We talked a little bit today about waste management and what to do about the waste of treated Ebola patients. Are any of that waste being transported across the country as part of this process?
My understanding is that some of the facilities are autoclaving it, and that the decision of the waste management companies was then to take that autoclaved material, which is, as far as everything we know, sterile, and then moving it to another state for incineration.
Okay. And so that is meaning that the waste is being transported across the country?
This is
I know
really
it's being autoclaved, but anything not being autoclaved that's being transported?
I'm not aware of anything in that category at present.
If it's being transported through various states, are the states notified of that transport?
I'm not familiar with the details. The EPA has been looking at different measures. They've had a meeting with the medical waste hauling industry to get input from them. We've worked with the Department of Transportation, and what we've done in the individual cases is ensure that there is the appropriate authority in place from the federal level, from DOT, and from the state level for the management of waste.
I yield back.
Mr. Long, you recognize for 5 minutes.
Thank you, Mr. Chairman. Doctor, is it Lushnak? Okay. You said that a travel ban, I think I'm quoting you right, would cause us to lose contact on how many people travel into this country. What do you mean by that?
Well, right now we have a system, and the system's an open system. We know when people are entering. We know where they're coming from. We know through our cooperative efforts with the Customs and Border Protection people of when they're arriving. They're arriving through 5 funnels, airports right now, and we have that connectivity. With a travel ban, you know, the essence of a travel ban is what? No one moves. However, it's
from those countries
that
are hot zones.
But at the same time, there is this potential that people move from country A to country B, from B to C, from C to the United States, and they can very well be from Western Africa. So in our, or my assessment of this, in essence, is what we have right now is a system, and a system that works following these individuals who are coming from Western Africa, from the affected nation.
But if they weren't coming, if we had a travel ban on them, how could we lose track of them?
Well, through multiple routes. It's rerouting from one country to another to another.
They're not going to have a passport or a visa or something that says where they started?
Well, again, that system can be sort of worked around, if you will. Right now we have a precise system, a system that is allowed to follow people who come in. We know where they're coming in from, which allows us to follow them.
I'm from Missouri, and you have to show me. I mean, that doesn't follow to me. It doesn't make any sense that if we had a travel ban from these hot zone countries, if they weren't coming in from those countries, how we could lose track of them if they're not coming in the first place.
Mm-hmm.
And if they want to do a workaround, we're going to have on their passport where they started, correct?
Potentially, if the passports are correct, if they've not been manipulated.
Dr. Fried, let me ask you, you were talking about the travel ban also. And you said that there's less people coming in now. Now, last time we were here, I believe it was October the 16th, I think, when you were last in to testify. At that time, the number we were using was 100 to 150 people per day. Do we know what that number is now?
From the data that I've seen until recently, it's been closer to 70 to 80 per day.
So it's been about cut by 50% for one reason or another.
That's my understanding.
And some people seem to think that if we just wrote a big check or gave you an unlimited checkbook that this problem would go away. Do you think enough money would fix this problem?
I think we have the ability to stop Ebola, but that's going to require doing what the emergency funding request asks for, strengthening our system here at home, stopping it at the source in Africa, and preventing another Ebola or Ebola-like situation where the world is most vulnerable.
There was a story out yesterday on the AP, and I'm sure you've seen the story of a nurse that was diagnosed with Ebola in Mali. And she was diagnosed with Ebola after she had deceased. That's the first time they knew she had Ebola. Now she worked in a hospital, in a care center that dealt with the elite. Some people would probably call them the 1% of Mali, but she dealt with people in the elite, also UN peacekeepers that had been injured. And after she deceased, they found out she had Ebola, and they didn't know where it come from. And the first Ebola death in Mali was 8 days after we had our last hearing in here. I think it was the 24th of October was the first death. Then they went back, and they figured out that there was they were trying to figure out how she had contracted this. And then they went back, and they found out that there was a 70-year-old gentleman that had come from, I don't know if it was Sierra Leone or where it was, but one of the, it was Guinea. He came from Guinea. And he apparently was the person that brought him to the hospital later deceased. They're not sure that was Ebola, but they found out that instead of kidney disease, he deceased from Ebola. And it's just disconcerting to me and my constituents how in a hospital in that area that they didn't even know. She obviously had symptoms before she passed away from Ebola. And one thing, just to wrap up real quickly, I know I'm kind of hitting 2 or 3 different areas, but Dr. Spencer, we heard one of the folks on the other side of the aisle earlier say that he self-quarantined, took care of himself. Was he not very misleading he didn't answer where he had been. He said he'd been home and in his apartment, and they checked the subway passes, and they checked his credit card and things, and found out that he'd actually been to the bowling alley, to a pizza parlor, and taken public transportation. Did he not, in New York?
So in terms of the Mali situation, we have 12 staff on the ground there now.
Right.
And
they've been there how long?
So we've had staff in Mali since before their first case,
okay,
helping them with Ebola preparedness. And then the 2-year-old who died, who you mentioned, was unrelated, as far as we know, to the current case. The 70-year-old gentleman who died actually lived in a town that's on the border.
I'm talking about a nurse that passed away, not a 2-year-old. I didn't mention a 2-year-old.
So the source case for that nurse is the 70-year-old who you mentioned, sir. He lived in the town of Kurumali, which is on the border between Mali and Guinea. And his Ebola diagnosis was not recognized. He had other health problems. People thought he had died from the other health problems. And there's now a cluster of cases there, and we're working very intensively to try to stop it, because given the challenges of Mali, if Ebola gets into Mali, it's going to be very hard to get out. So we're hoping to be able to stop that.
And they went back 3 weeks later and tried to sanitize the mosque that he had been prepared for burial in, correct?
That is my understanding.
So I would like to see, as I said back on the 16th, a travel ban, and I still don't understand how you can lose track of people that never came in the first place. I yield back.
Thank you. Ms. Elmer is recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you to our panel. Dr. Frieden, one of the things that I have been doing is reaching out to the hospitals in North Carolina, and in my district alone, I have a number of hospitals that are saying that they're experiencing delays in receiving some of the protective equipment and protective wear that they need, specifically short supply of Tyvek suits, shrouds, and N95 masks. They're being told that it could be 6 to 8 weeks or possibly even longer What does the CDC, what role does the CDC play in this, and why would there be a delay in this equipment?
We've looked at 3 levels of hospitals. First, the hospitals around the airports. We want to make sure that they have ample supply. Also, the hospitals, I should say, which are the specialty facilities like Nebraska, Emory, and NIH. Second is the facilities where large numbers of people from the African diaspora live, where we might have another case. And third is all of the other facilities in the country. And given the number of facilities, there is not currently enough PPE on the market of some of the products to give every hospital as much as they would like. At CDC, we have a strategic national stockpile, and that stockpile already has enough PPE to distribute to hospitals that urgently need it within hours. We also have worked through our rapid Ebola preparedness teams, or REP teams, with several dozen hospitals around the country to get them ready. When we worked with them, we found that although they might have shortages of some protective equipment, they have been able to meet those shortages by contacting the manufacturers. And I understand that what Dr. Lurie and her office has done is to work with the manufacturers to both scale up, so they're working very hard to produce more, and prioritize facilities that are most likely to need facilities. For some of the products, such as N95s, we have ample supplies in the Strategic National Stockpile, and we could provide as needed.
Okay. And Dr. Lurie, do you want to comment on that as well?
Sure. One of the things that my office has done through our critical infrastructure program since the very beginning is reach out and work with the manufacturers and distributors. I've personally spoken to the leadership at each of the manufacturing companies, and each of them now have gone to 24/7,
manufacturing.
3 shifts a day manufacturing. In addition, they've all made a commitment to work with us, and we're actively doing this so that if a hospital is on our first list of being really ready to take care of Ebola patients or needs PPE urgently, they will prioritize the orders. What they told me very interestingly is that because a lot of people are frightened, that many hospitals are, they think, double and triple ordering PPE from different distributors and different manufacturers because they want to be sure that they get some. So part of our job is to be sure, working with them, that people get what they need. And as Dr. Frieden said, through the Strategic National Stockpile, we're very confident that we can get enough PPE to any hospital that has an Ebola patient.
Okay.
We also want to be sure that they have enough. The manufacturers and distributors have also developed some training material, so you don't have to train on real PPE. They'll go out to a facility and let you use other kinds of samples to practice.
To practice, okay. Dr. Frieden, in relation to travel, I've been in touch with my local hospital, or excuse me, my local airport, Raleigh-Durham International, and obviously that is not one of the 5 designated airports, but I am concerned about our Customs and Border Protection officers. They're the first line. They would be the first to come in contact. They are not healthcare professionals. With this increased threat of Ebola, is the CDC prepared or has dedicated additional funds to those airports outside of the 5 designated to help with training and personnel issues?
Part of the emergency funding request is to ramp up some of the quarantine services. Our focus is working in the 5 funneled airports now, and we've worked very closely with Customs and Border Protection. It's been an excellent partnership. We've provided training, information, but we understand that there's a desire for more information. With the funneling process, we're now able to ensure that almost all travelers go to those 5 airports.
One last question. Is the CDC working with OSHA and Department of Labor on helping hospitals to be trained and up and ready for the preparedness?
Yes, OSHA has been part of the CDC teams and offers its services and information to hospitals that are working on preparedness.
Okay, great. Thank you. And I just want to say also that I wish that Mr. Klain was here with us today as part of this panel, because I think the information that our new Ebola czar, that he could provide some very important information. So I just want to state that. Thank you.
The gentleman yields back and now recognize Mr. Olson for 5 minutes.
I thank the chair and welcome all our witnesses. My home is Texas 22. It's a suburban Houston district. Many folks who live there work down at the Texas Medical Center and may live in rural parts of Texas 22, Needville, Texas, where cotton is still king. The Ebola case in Dallas spooked them. It spooked them badly. 2 schools in Cleveland, Texas, shut down for days because 2 students were on that flight coming back from Cleveland with that nurse who'd been exposed. Cleveland is closer to Houston than it is to Dallas. Galveston, Texas had a cruise ship dock there. Came home early because a nurse from Dallas self-imposed quarantined herself in her cabin. The waste coming from Dallas is coming down to Galveston, UTMB, to be incinerated in 55-gallon drums, 1,800 degrees Fahrenheit, to completely burn the waste from treating the Ebola cases in Dallas. Everything goes to Galveston comes through Texas 22. One common frustration I've heard over and over back home is the deluge of information coming from CDC and all of y'all. It's confusing and overwhelming. I've heard that from big hospital systems and small providers. Emergency centers like St. Michael's in my hometown of Sugar Land, Texas. I'm worried about the little guys like St. Michael's. I have a question for all 3 panelists. First one's for you, Dr. Frieden. What is your organization doing to ensure that small guys like St. Michael's are ready if an active Ebola patient shows up at 2 in the morning on Thanksgiving night?
3 things. First, we're working with the travelers themselves so that they know where to go. They have a number to call. They're checking their own temperature so that they can promptly identify if they have symptoms and be cared for before they become severely infectious. Second, we're providing information through our website, through webinars, through demonstration and training practices to hospitals throughout the U.S., as well as hands-on training through our rep teams and our CERT teams if there were to be a case. And third, we're working very closely with state health departments, which we really think are key here. And one of the critical components of the emergency funding request is strengthening and providing more resources to state health departments exactly for this, to strengthen infection control for Ebola, other deadly threats, and things that are daily endangering the health of patients throughout the country. And we think that state health departments and hospitals have a critical role to play, and to maximize the impact of that, it will require the resources, and it will require taking an approach that addresses Ebola as well as other deadly threats and strengthens our everyday systems of infection control.
Dr. Lori, how about yourself, ma'am? HHS, helping St. Michael's.
Helping St. Michael's. Well, so one of the things that we have done through our hospital preparedness program is reach out to all of the hospitals around the country. Hospitals are now organized into coalitions, which are community-level collections of hospitals and dialysis facilities and nursing homes and others. Texas has a very well-organized system of this, and reaching out through them, they are able to reach to St. Michael's, number one, to say if they needed personal protective equipment, could they get it through their coalition? If they needed help with exercises and training, they could get it through their coalition. Number two, as I mentioned before, we've had a very aggressive national outreach and education campaign that's been open to healthcare providers, including healthcare providers from St. Michael's and anywhere else around the country. People can take advantage of numerous phone calls and webinars. They've reached nurses, they've reached doctors, they've reached hospital administrators, they've reached EMS professionals around the country. At this point, we've reached over 360,000 people across the United States with this. So finally, it is our goal that every hospital, including hospitals like St. Michael's, will be able, as Dr. Frieden says, to think Ebola, to recognize a case, to safely isolate a case, and to be able to get help. And finally, through the state health departments, and I know you'll hear from Dr. Lakey in a little while, they called the state health department, and if they have questions or concerns about a patient with a Ebola-like syndrome, the state is in a very good position to help as well.
And Dr. Leszek, after your question earlier, but one more question to you, Dr. Frieden. You were quoted on October 2nd saying, this is a quote, essentially, any hospital in the country can take care of Ebola, end quote. Do you stand by that quote today? Any hospital?
Clearly, it's much harder to care for Ebola safely in this country than we had recognized. It is the case that every hospital in America should be ready to recognize Ebola, isolate someone safely, and get help so that they can provide effective care. That's why we established a CERT team, CDC Ebola response team, that will fly in at a moment's notice for a highly suspected or confirmed case to help hospitals throughout the country.
Thank you. Yield back.
Now recognize Mr. Johnson for 5 minutes.
Thank you, Mr. Chairman, and I too want to thank the panel for joining us today. Thank you very much. Dr. Frieden, have any other states also applied stricter standards than the CDC has in terms of how to handle Ebola?
CDC guidelines are just that for states, and states are free to be stricter than that. We're gratified that most have followed our standards, and really what we say is pretty clear.
But do you know if any states have stricter standards?
Yes, some do.
Okay, all right. Why do you think the states are adopting stricter standards than the CDC? Are you confident that your standards, the CDC guidelines and standards, are strong enough?
We believe that our standards, if followed, are protective of the public. They require that people who may be at any elevated risk, or some risk rather, that those individuals have their temperature monitored every day by direct active monitoring. And that is something that allows us to interact with the person, to talk with them, and to determine on an individual basis if they should stay home that day or if they might be reasonable to allow them to do other things.
Have you talked to any of the states that have stricter standards to find out their rationale for the stricter standards?
I've had some communication with some of the individuals involved and understand some of their thinking process. The number of individuals who are subject to those stricter standards is really quite small, and all of those individuals, by our standards, should be in what's called direct active monitoring, which means someone actually watches them take their temperature each day, has a conversation with them, and confirms that they're healthy and don't have a fever.
Okay. The last time that you were with us, we talked about having tested these standards. Have the standards been fully tested, the guidelines been fully tested across the country? Back to what my colleague from Texas just mentioned, so that every hospital knows what to do? Have they been tested?
So the standards in monitoring travelers are being implemented now by every state in the country, or virtually every state in the country, tracking people coming back from West Africa, monitoring them for fever.
Have they been tested?
I'm not sure I understand your question, but with respect to the travel...
Then let me explain the question. You know, going back to my military experience, and I think some of the gentlemen here can understand that, we do things called operational readiness inspections. We don't wait for the bullets to start flying before we know what we're going to do when they do start flying. You come to Appalachia, Ohio. There are lots of little community hospitals that dot our region. Are those hospitals fully up to speed? Have they tested and have they signed off on any kind of guidelines that they have tested their Ebola process?
In terms of hospital preparedness, many hospitals have undertaken drills. We've also had...
Has CDC mandated any drills?
CDC does not mandate that hospitals do drills. We provide guidance, support, and resources for hospitals.
Have you recommended that they...
Yes, and we've been directly involved with them in doing that, and we've reviewed for the rep-visited hospitals, those that are most likely to receive a case. We have visited those hospitals. We've overseen their drills. We've overseen their preparedness, and we've worked with them on advancing their preparedness.
Okay. It's my understanding there are several Ebola centers scattered across the country, also referred to as infectious disease centers. Most of them have a patient capacity of 1 to 2 people. As of right now, most individuals with Ebola treated in the United States have been transported to one of these centers to better manage their illness. In the event that a larger number of cases were to show up in the U.S., how does the CDC plan to treat a patient load that exceeds the capacity of available bed space in those centers?
The challenge of a cluster of Ebola would be substantial, and it would be a matter of using all available...
Define a cluster.
Would be a handful of cases, could be 5 or 10 cases. In a kind of practical worst-case scenario, this is something that could be seen. In this case, we would use all available local resources, if need be, surging healthcare workers in, and we would also transport patients to facilities around the U.S. where they could be treated.
Do we have, I mean, these centers are set up to handle 1 or 2 patients because of the unique requirements of the disease, the virus. Do we have transportation systems that are capable of transporting Ebola patients in, if that outbreak were to be bigger than the 1 or 2 that we're talking about?
We have some transportation facilities for Ebola patients in the U.S. We are working with the State Department and others to increase the capacity to transport patients.
What about those who might be transported to other places? Would they be receiving lower quality care in your mind than at one of the infectious disease centers?
No, we think the quality of care can be provided. It's really an intensive care unit care, and CDC clinicians have consulted on the care of every single patient cared for in the U.S. and provided to each and every one of them access to experimental treatments and state-of-the-art care.
Okay.
Gentleman's time has expired. Now,
thank you. I'll yield back.
I can recognize Ms. DeGette. Do you have questions that you wanted to ask?
Go ahead.
She's going to yield at this point. I now recognize Mr. Griffith for 5 minutes.
Thank you, Mr. Chairman. Dr. Frieden, I'm going to try to move through these as quickly as I can, so I appreciate short answers. You are aware that the Secretary of HHS is able to transfer funding from your department to other departments, isn't that correct? She can take funding from your department and stick it somewhere else, isn't that correct?
There is limited transfer authority as far as my understanding goes.
And when that happens, are you notified? Is she required to tell you that she's transferred funds?
As far as I know, yes.
And has the Secretary transferred funds in 2014 from the Division Handling Emerging and Zoonotic Infectious Disease? Yes or no?
I don't know the answer to that offhand.
Can
I could
you get that
back you with that
information for me?
Yes.
And I believe that that particular division would be a part of the Ebola response. I'm correct in that?
That is correct.
And do you know whether or not the Secretary has transferred money from the CDC's global health programs?
I would have to get back to you on that as well.
All right. Likewise, the same would be on CDC's Public Health Preparedness and Response Division.
I'd have to get back to you.
And both of those also would be a part of your Ebola response, wouldn't they?
Yes, they would. Yes, they are.
Now, you've indicated that you don't know about whether these monies were transferred. Do you know if any monies were transferred at all during 2014? Do you have any information?
There is a Secretary's transfer, but I don't know the details of what has been done.
Okay. And so you don't know the details. Do you know, so you would not know if any of this was transferred to help support the financial underpinnings of the of the Obamacare, ACA?
I do not know.
And likewise, do you know if any transfers were made to the administration, by the administration, for children and families to care for increasing number of unaccompanied children who arrived in the United States?
I'm not familiar with that financial.
You're not familiar with that, but would you get us the answers to all of those?
We can certainly get you those answers.
Likewise, I'm curious, the President apparently has requested a fair amount of money, and part of that related to Ebola, and part of that is a $1.54 billion in contingency funding. Some of that is supposed to go to HHS. It says in his letter to make resources available to respond to evolving epidemic both domestically and internationally. And I'm looking here, and it says that while $751 million of that is to go to HHS, it then talks about transferring those funds over to Homeland Security to increase customs and border control operations. Have you been in the loop on that? Do you know what kind of money you all are getting, and what are they talking about with customs and border control operations?
We work very closely with CBP, and we understand the need for contingency funds for Ebola in case, for example, Ebola would spread to another country that required a very intensive, extensive response. So that flexibility is a critical component of the emergency funding request.
Okay, and that funding request is, as was pointed out in an editorial by David Satcher, and I hope I'm pronouncing that right, a former director of CDC and a former Surgeon General. That request by the President is actually greater than what we've been spending on Alzheimer's. Isn't that correct?
I don't know Alzheimer's funding details offhand.
All right. And in regard to Mr. Klain, have you all had sit-down face-to-face meetings?
Yes.
And how many of those meetings have you all been?
Well, I'd have to get back to you with the exact number.
If you could get me that number, I would greatly appreciate that. That would be very, very helpful. Now, in some of the outbreaks in the past, historically in Ebola that have occurred in Africa, isn't it true that there are some times that we have an outbreak when we don't know where the disease actually came from, where it was picked up?
We have not identified definitively the animal reservoir of Ebola. We think it may be bats or bushmeat, but we have not determined that. We've determined it for a similar virus, Marburg, from research that CDC scientists did.
And the meat, I understand, the bats, would that be from excrement? I mean, how would the bats spread it, or are they eating the bats as well?
Well, it may be saliva. It may be carried. Bats, as mammals, carry a lot of pathogens that are similar to the pathogens that infect humans.
But this is just one of many areas where we are not really 100% sure of how the disease is spread, particularly in Africa.
Well, I would clarify, we're not sure of the animal reservoir. From all of the experience we've had, spread among human populations is from either unsafe care or unsafe burial in the outbreaks that we've assessed so far.
So, but that's once there's been an outbreak, but there are occasions when the outbreak just starts and nobody had it there before, so it couldn't have come from human contact. It had to come from this animal reservoir, and we're not sure exactly what animals carry it, whether or not it's, you indicated spittle, excrement, what else. We do know that it's transmitted if you eat a diseased animal. Is that correct?
It may be actually not so much the consumption of bushmeat, but the hunting and handling and cleaning of bushmeat where you may get exposed to blood and other body fluids.
Okay. I appreciate it and yield back.
Now I recognize Ms. DeGette for 5 minutes.
Thank you, Mr. Chairman, and I want to apologize to you and to the panel for running out, in and out. The Democratic leadership right now is actually working on who our next ranking member of this full committee is going to be. It's not going to be me. Thank you for your vote of confidence. So I just want to ask a few questions, and then I'm going to leave you in the capable hands of Mr. Green. Dr. Frieden, the first thing I wanted to talk to you about is the contingency fund that has been requested in the emergency supplemental. What exactly is the purpose of that fund, and what would it be used for?
The contingency fund is to deal with the unpredictable nature of Ebola, the possibility that it might spread to countries where it is not currently in place and might require very extensive, expensive control measures there. Also that we might have new interventions, such as a vaccine, and need a large and potentially expensive program to implement a vaccine program in affected communities and for healthcare workers.
And why would you need to do that through a contingency fund and not through an additional emergency supplemental if that situation, either of those situations presented themselves?
You know, in the words of one of my staff at CDC, in the case of Ebola, it's the lack of speed that kills. We need to be able to respond very quickly to changing conditions on the ground.
And we're seeing that right now in Africa, is that right?
That is.
Everything's changing very quickly in Africa.
Absolutely. We're responding to a cluster in Mali. We're moving out with CDC disease detectives into very remote rural areas to address clusters of disease before they become large outbreaks.
Do you have a sense of why the number of cases in Liberia has recently dropped?
We believe this is proof of principle that the approach that we're recommending can work, but we're still seeing large numbers of cases in at least 13 of the 15 counties of Liberia. We've seen that decrease taper off so that we've seen a leveling off of cases that have been reported. Every one of those cases needs intensive follow-up, contact tracing, monitoring of contacts, and we're still having perhaps between 1,000 and 2,000 cases, new cases per week in West Africa. So this is still a very large epidemic.
Well, and that kind of leads me to my final question, which is you have said repeatedly, and frankly, there's been a lot of pushback on this, not just from this committee, but from lots of other folks. You've said repeatedly that you don't think that travel bans and quarantines are the way to go about addressing this, and I'm wondering if you can tell us whether that's still your view, and if so, why, and if it's not, why not?
we're willing to consider anything that will make the American people safer, any measure that's going to increase the margin of safety. And one of the things that we've done is to implement a travel system so that people leaving these countries are screened for fever, arriving in the U.S. are monitored for fever, are linked with the local health department. We are now working with state and local health departments to monitor each of those individuals each day, and we're seeing very high adherence rates to that. So we have a system in place now. The risk to the U.S. is directly proportional to the amount of Ebola in West Africa. The more there is, the higher our risk. The less there is, the lower our risk. We have to reduce the risk there by attacking it at the source. But whatever we can do to reduce the risk to this country, we're certainly willing to consider.
So you would still consider a travel ban if that seemed like the only solution?
If there were a way to ensure that we didn't lose that system of tracking people through every step of their travel and once here, we would consider any recommendation, but it's not CDC that sets travel policy for the U.S. government.
Right. And what I'm concerned about is if Ebola goes to other countries in Africa in general, it'll be harder and harder to trace where people came from.
The spread of Ebola to other places in Africa is one of the things that we're most concerned about because it would make it much harder to control. We were able to work with Nigerian authorities to stop the cluster in Nigeria. Right now, Mali is in the balance of whether we'll be able to stop the cluster there before it gains a foothold in Mali. But the longer it continues in the 3 affected countries, the greater the risk that it will spread to other countries.
Great. Thank you. Thank you very much, Mr. Chairman.
Gentleman yields back. Now, Mr. Terry is recognized for 5 minutes.
Ask unanimous consent to be able to ask questions.
Yes, you're recognized. Yes.
Thank you. Dr. Frieden, from Nebraska, and really proud of the efforts of University of Nebraska Med Center. At least we're topping something. It's not football, but it gives us a sense of real pride, despite the last patient outcome, which they did heroic efforts. But also in that regard, they seem to have been the ones that, especially in comparison to the Dallas Baptist Hospital, were kind of that they were setting the standards on the practices. And so that begs the question, or at least we should ask the question of whether the CDC should develop an accreditation type of program on infectious disease programs to ensure that these hospitals maintain a level of competency and readiness. Should you, or is something like that ongoing?
Well, first, we really appreciate the facility in Nebraska and their willingness to step forward and the phenomenal care they've provided to all of the patients who've come to them. And despite the outcome of the physician recently, we know that heroic measures really were undertaken, and the staff there really deserve the gratitude of all of us, and we appreciate them. We appreciate also their willingness to consult with other facilities and to share their experience, because that's critically important.
Which they have done, and
yes.
that hospitals like Johns Hopkins is asking them how to do it is a source of pride for us as well.
What we've approached is something called the REP team, the Rapid Ebola Preparedness Team, where we send a team in to work with the facility to outline every aspect of their preparedness and to see how ready they are, and then to provide recommendations for what more they can do. We've also worked with state health departments so that they can determine which are the facilities within their state that are most appropriate to take patients with Ebola or other infectious diseases, because they're really best prepared for that. In terms of accreditation, that's something that we have discussed with the Joint Commission. Whether that makes sense in the long run or not is something that we're open to exploring.
All right. As a layperson, it seems to make sense that you would have an area where there is one hospital that has that level of accreditation. And then it begs the question that if they are going to be that go-to hospital in a region or a state, whether there should be maintenance funding behind that. What do you think?
We certainly believe that they should receive resources. There's funding within the emergency funding request, both from CDC and from ASPR, to support specialty facilities such as the one in Nebraska.
So that the question then is, just to clarify, would that be part of the President's requested dollars?
Yes, it is.
Dr. Lurie?
Yes, it is.
Very good. So, and again, Dr. Frieden and Dr. Laurie, one of the experiences here is that we know that, let's see, UNMC I think has 11 units, but the reality is they can probably only have 3 patients at a time because of all of the collateral circumstances. So do we need more biocontainment units like what Emory and UNMC have, Dr. Frieden?
We think we need some increase in the number of facilities that can safely care for someone with Ebola or another deadly infection. We've been working very closely with hospitals throughout the country to increase that capacity, and the emergency funding request would enable us to really get to the level where we would have a greater degree of comfort with the facilities out there and the capacity.
Just to clarify that some of the dollars that would be in the emergency funding, the President's request would be to expand the number of biocontainment units.
Yes.
Very good. And one of the questions about having 3 patients at UNMC, these folks don't have any insurance and they're holding the bag for the funding of those patients. Is there anything with HHS, Dr. Laurie, or CDC that can reimburse these facilities for the health care costs?
I believe that Secretary Burwell indicated in the hearing last week that we're very open to mechanisms that would make them whole for the expenses that they've had.
Open to it and doing things, or there's a big gap between those two. Is there any further discussions to reimbursing, Dr. Laurie?
So I think we understand that the cost of caring for these patients is quite substantial, and as Dr. Frieden said, Secretary Burwell indicated that she would look forward to working with Congress on this issue, yes. I might also just add, in terms of the emergency funding that is necessary, it is clear that hospitals that are going to take care of Ebola patients need additional training, and we very much appreciated the fact that University of Nebraska and Emory have been now working side by side often with the rep teams to help with that. Part of a funding request would also establish something that would look like a National Education and Training Center that would move to another level, I think, of preparedness for hospitals that really wanted to attain that and to get help with doing that.
Okay. Thank you very much. My time's expired.
All right, that concludes the questions for this panel. We thank you, and also members may have some other additional questions, or repeat your responsiveness to those. We do appreciate the availability of all of you in responding to us, so I thank you very much.
Thank you.
As this panel is moving, I'll begin to introduce the second panel so we can move forward here, and I'll introduce 2 of the panelists, then we'll ask Mr. Terry to introduce one as well. We'll start off here. Just a moment here. First, Mr. Ken Isaacs is the Vice President of Programs and Government Relations for Samaritan's Purse. Also, Dr. David Lakey is the Commissioner of the Texas Department of State Health Services, but is here today testifying on behalf of the Association for State and Territorial Health Officials. Correct? And Mr. Terry, if you would like to introduce the other panelists.
I would be honored to introduce Dr. Jeffrey Gold, the Chancellor of the University of Nebraska Medical Center and Nebraska Medicine. He is recent to Nebraska, but certainly making a huge impact, especially with the Biomedical Containment Center, where they have hosted 3 Ebola patients, and they are setting the standards for how to treat the Ebola patients and setting the standards for the employees that come in contact and work with those. UNMC is a great facility. They're very forward-thinking. They're probably they're ranked very high in a lot of areas of care, but it's probably the research that is making them known internationally, and so I'm proud to introduce Dr. Jeffrey Gold.
Thank you. Well, for the panel, you're aware the committee is holding an investigative hearing, and when doing so has the practice of taking testimony under oath. Do any of you have any objections to taking testimony under oath? The chair then advises you that under the rules of the House and the rules of the committee, you are entitled to be advised by counsel. Do any of you desire to be advised by counsel during your testimony today? And all the panelists have said no. In that case, would you please rise and raise your right hand, and I'll swear you in. Do you swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth? All have answered affirmatively. You are now under oath and subject to the penalties set forth in Title 18, Section 1001 of the United States Code. We're going to ask you each to give a 5-minute summary of your written statement. We'll begin with Mr. Isaacs.
Thank you, Chairman Murphy, and esteemed members of the Council and fellow guests of the committee for letting me testify today. It's a privilege to be before you regarding the developments of the Ebola outbreak in West Africa. Since Ebola entered Liberia in March through its explosion onto the international spotlight in July, and even now, when it appears that the disease may have crested in Liberia, the world has learned much about Ebola, but I want to stress today that we've also discovered that there are many important questions that we simply do not know the answer to, and we need to know the answer to them. I want to run through them quickly. I will say as an offside that going last means you have to reshuffle everything you're going to say because it's all been said before. But I think that a good question to know the answer to is how are the doctors who are returning to America becoming infected? Some of those doctors have been our staff. Some of those doctors have been our coworkers that were treated at Nebraska. And even recently, the gentleman in New York, they were all wearing level 4 gear. How did they get infected? Can the virus live in other mammals besides primates, bats, rodents, and humans? Now, I've worked and lived in Africa for about 25 years, and I've eaten my share of bushmeat. It's not always bats. It's mostly something like a groundhog. And so what does it mean? Where does the virus live? And the point is that can it jump into the animal population here? We need to know that. As with other viruses, is it possible that Ebola can be asymptomatic, sort of a typhoid Mary kind of a thing? We know for a fact of 3 situations where blood were drawn on patients who were non-febrile, who were non-symptomatic, and they all 3 tested positive. One of the problems that exists today in Liberia, where Samaritan's Purse is working, is that there is no protocol to move blood from Liberia to Rocky Mountain Laboratory where these kind of tests would need to be checked and results found out. You know, I will just say I'm not trying to be a fearmonger, but I think that there are things that we need to look at critically, and we should not be afraid to ask questions. In my written testimony, there is one paper from the New England Journal of Medicine that reports that 95% of the cases of Ebola incubate in 21 days. The inference is 5% of them don't incubate until 42 days. We need to know what that 5% means. While the media coverage is already decreasing and people maybe feel like that Ebola has peaked, we do not think it has. I totally agree with Dr. Frieden. I think that we need to vigorously and in a sustained manner fight this disease in Africa. I think that no card can be taken off the table. And I think that while we hear from many health experts that we know how the disease is spread, we know how to fight it, and we know how to stop it, the truth is that lessons come at a great and expensive and painful price. And when a new lesson comes about, then all of the policies are changed. So I heard the word humility used several times today by different members of the panel, and I think that that is a good word because Ebola is a humbling disease. When you talk to the epidemiologists, they're all over the place. CDC is saying 1.5 million people by the middle of January, and the World Health Organization is saying that in December maybe 10,000 people a week. The point is we don't know. Several things that that I want to say right quick is we're seeing the disease go down in Liberia today as it regards empty hospital beds, as it regards deaths, and as it regards patient loads. But at the same time, we're seeing a significant increase in Sierra Leone, the country next to it. So it's clear that the disease has not peaked. Actually, if anything, I would say that it perhaps has ran its course, and we don't know what its course is. And if you look at the epidemiological charts in Sierra Leone, it is peaked 2 times before. So the question really is, are we at a peak or are we in a trough before the next uprise? Practically speaking, I think that a couple of things that we need to look at is travel ban, travel restrictions, or I like to say travel management should not be taken off the table. The real threat to the United States, I do not feel, is going to be how many people are sick here. The real threat to the United States is what will happen if the disease spreads into countries that cannot handle it. And I'm not talking about Africa. I'm talking about in the sub-Indian continent. I'm talking about in India and China, in Pakistan, Myanmar, Bangladesh, countries that are highly populated, that have low public health standards and have low hygiene standards. You could see a death toll that would be unimaginable, and the impact around the globe would affect us as well. So I think I'm out of time there. Thank you.
Thank you. Dr. Gold, you're recognized for 5 minutes. You have to pull it real close to you. Thank you.
Chairman Murphy, other members of the subcommittee, thank you so much for the opportunity to discuss the Ebola outbreak and the nation's response and how the nation can maintain a state of readiness to respond to future highly infectious diseases. I'm Jeff Gold, and I have the honor of serving as Chancellor of the University of Nebraska Medical Center. My testimony today will focus on the challenges of dealing with Ebola and our nation's readiness to respond to highly infectious diseases. As has been said many times earlier today and well before, the United States is dealing with a serious public health crisis with the Ebola outbreak in Africa. It is a crisis that the United States has both the expertise to contain and to help resolve. One of the most pressing goals to accomplish from the Ebola outbreak is how to best leverage the know-how to train and to better prepare the nation's healthcare system to combat future highly infectious threats like Ebola here and around the world. The University of Nebraska Medical Center is recognized as a national resource for our readiness to provide care for Ebola patients and also our ability to provide training on Ebola and other highly infectious diseases. We have successfully treated Ebola now in 2 patients and not in 1, most recently passed away yesterday. We have provided consultations to many hospitals, clinics, emergency departments across the United States, including Bellevue Hospital in New York, on how to deal with therapies for patients who arrive in their hospitals, their emergency departments, etc. Our readiness is based upon more than 9 years of preparation, protocol development, and team training to deal with highly infectious, deadly diseases. As a result, we are now responding to literally hundreds of hospital inquiries across the nation, asking how to prepare if Ebola arrives in their community. Emory University Hospital is experiencing similar inquiries, and we are working closely together. One step that we took to respond to the immediate national demand for information and training was to work with Apple Computer to convert our 9 years of protocols and procedures into easily accessible and completely downloadable multimedia materials and videos for healthcare providers. That was accomplished in 1 week, which is now available through Apple and through public media and can be accessed on any personal computer, with well over thousands and thousands of physicians and members of the public who are downloading content specifically about personal protective equipment and others. You might ask, why Nebraska? Why is the biocontainment unit that we opened in 2005 in existence? This followed the 9/11 attacks. It was built upon concerns about anthrax on congressional offices and SARS attacks. We recognized that the commonness of international travel increased the chance of global spread of highly infectious diseases. Our unit has written and rewritten protocols and procedures and collaborates consistently with national organizations and other medical centers. We rigorously train with local emergency responders, state emergency management, and military units through our relationships with STRATCOM and others. We spend a great deal of time considering the response plan if another highly infectious disease were to occur and how this could be scaled. The university is also a Department of Defense authorized university-affiliated research center, which specializes in developing medical countermeasures to weapons of mass destruction, including highly infectious viruses. We have a history of conducting extensive research in these areas, including vaccines, antivirals, early detection, etc. What has become obvious from this Ebola crisis is that a national readiness plan is absolutely necessary. Our biocontainment unit is one of 4 in the nation. The capacity and the number of units in the nation must be increased, and a national readiness plan that trains healthcare providers must be established. The number of actual beds is under 20. The number of usable beds is under 10. and I assure you that every unit such as ours will always maintain at least one bed if is ever needed for a staff member that becomes ill. That immediately knocks the number down by 4, 5, or 6. The University of Nebraska Medical Center and Emory are working closely with the CDC and HHS on how training might be most effectively delivered. It must begin soon, and we have done so in advance of any funding considerations. As Congress considers funding, I urge that this include a number of items, and I will just read them by title as they are contained in my briefing documents. A national training in Ebola and highly infectious diseases to develop a tiered training system. Training should include setting up an accreditation program that independently, nationally accredits organizations, emergency departments, etc., to establish and maintain their skill level of readiness. An annual maintenance of funding for increased role of existing biocontainment units to maintain their readiness. We have funded the readiness of our unit totally off of internal dollars up to this point. Funds to expand the number of treatment centers and existing biocontainment units, specifically to increase bed and staff capacity within existing units as well as new units. And finally, reimbursement for care for Ebola patients not covered by insurance. Ladies and gentlemen, we have the expertise and know-how to contain Ebola and other infectious threats. However, in order to do this, we must ensure that our nation's healthcare professionals are adequately trained, properly equipped, and rigorously drilled. I thank you so much for this privilege.
Thank you, Dr. Gold. Now, Dr. Lakey.
Thank you, Chairman Murphy and members. For the record, my name is David Lakey, the Commissioner of the Texas Department of State Health Services, and I've been in that role now for 8 years. This last month has been one of my most trying and tough months as the Commissioner of the Department of State Health Services. On September 30th, 2014, the Texas State Public Health Laboratory, a laboratory response network laboratory, diagnosed the first case of Ebola in the United States. The diagnosis of Mr. Duncan with Ebola set in motion a process we in public health refined through continued use, tried and true public health protocols, including identifying those individuals that have had contact with people that have been infected, making sure that they're monitored, providing care to those that have been infected, isolating those individuals, and when needed, using quarantine. The magnitude of this situation really was unprecedented. While Mr. Duncan was one man staying in one city, in one state in the country, the outcomes associated with his case could impact the whole state and possibly other parts of the United States. We at the Department of State Health Services, along with our colleagues in Dallas and our colleagues at the Center for Disease Control and Prevention, took the responsibility to contain the spread of this disease very seriously. We organized a local incident command structure to handle the event, and at a state level, we activated our emergency response management centers. While our core mission was simple in concept, to protect the public's health by limiting the number of people exposed to the virus, the challenges associated with carrying out that mission were numerous. The care of Mr. Duncan presented its own challenges, identifying the first person in the United States infected with this disease, the infection control challenges, waste management and transportation, the availability of experimental treatments and vaccine, training for healthcare workers on the higher standards of infection control, and personal protective equipment, guidance, and supplies. And when Mr. Duncan regretfully passed away, we handled issues related to caring of his human remains, which remained highly infectious with Ebola for months after death. Unfortunately, during the care of Mr. Duncan, 2 nurses became infected. Nurses who had put their lives and their careers on the line to take care of Mr. Duncan and to protect the public's health. Concerns relating to the handling of these 3 Ebola patients included questions about decontaminating their homes, their automobiles, decisions about how to handle their personal effects, the monitoring of pets, and patient transportation issues, and addressing the public's concerns. Identifying potential contacts and locating them and monitoring those individuals had some risk of exposure that also involved many challenges. Decisions about who to quarantine and what level of quarantine, balancing public health and an individual's rights, providing accommodations for those confined to one location for the 21-day monitoring period, quickly processing control orders, coordinating 2 symptom checks a day for each person under monitoring, and managing the transportation and the testing of laboratory specimens. Throughout all these specific challenges, our experience in Dallas exemplified common requirements for successful responses to emergency situations. Having clear roles and responsibilities among the various government agencies and entities that are involved, strong lines of communication, and an incident command structure staffed by trained emergency management and public health professionals to ensure the response's cohesive direction. It really requires a partnership at all levels of government and throughout state and federal government. The outcomes in Dallas proved the strength of the public health process. Hundreds of people were monitored in the state. 2 cases of Ebola resulted from the direct care of the index case, and they were detected early in the disease onset, and they recovered. No cases resulted from community exposure. At this time, like other states, Texas is providing active monitoring for individuals who arrive in the United States from one of the outbreak countries. Texas has monitored approximately 80 individuals under the airport screening process. Texas is also, like other states, working to ensure that capacity exists in the state to care for patients with high-consequence infectious diseases like Ebola. 2 centers currently are able to stand up on a short notice to receive a patient, and Texas is working to identify additional capacity within our state. As Ebola screening and monitoring transitions into our routine processes, our focus in Texas is now shifting to include complete evaluation of the response in Dallas and a discussion of how to improve the public health response system in Texas as a whole, and sharing our experiences and our lessons learned nationwide. Governor Perry has put together a task force for infectious disease preparedness and response to evaluate the Texas system and to make recommendations for improvement. And we take that extremely seriously. I believe this discussion among governmental and non-governmental individuals, among varied stakeholders, and including experts in pertinent fields, will result in a Texas and the nation being better prepared to handle the next event. While we do not know what form the next event will take, we do know that there will be another event. As I tell my colleagues at the state and national level, it's my expectation that as a Commissioner of Health, that I'm going to have to manage one major disaster each and every year, one unthinkable event per year. And that is why the funding that is provided to states through the Hospital Preparedness Program and FEP is very important to what we do, and that partnership is really critical. And finally, I want to thank my colleagues at both the Dallas County Health Department and the Center for Disease Control for their work and their support, and this really was a team effort. Thank you, sir.
Thank you. Dr. Gold, I know you have some travel plans. We have about 20 minutes of questions. Will you be able to accommodate that?
Yes, sir, whatever your needs are.
Thank you very much. I appreciate that. And I'll recognize myself for 5 minutes. Dr. Gold, you mentioned a number of comments about what needs to be done with the administration's request for funding. I don't know if you've had a chance to read it. Have you?
At least in general terms,
okay.
Yes.
So would you know whether or not there's an adequate plan to support the request yet? I don't want to put you on the spot.
I don't think the granularity is in the written materials that have been provided.
Would you do us a favor, as someone at a hospital dealing with this, could you make sure you get to the committee specific recommendations? In fact, I would ask that of all the panelists, you've all dealt with this, it would be very, very helpful to have that kind of granularity. Thank you. Mr. Isaacs, you've been to Africa? You've been to Africa?
Oh, yeah. And a lot of times.
The CDC has guidelines for health monitoring and movement for healthcare workers who have been treating Ebola patients in Africa. Now, they classify as some risk those professionals who have had direct contact with a person sick with Ebola while wearing personal protective equipment. You have cited that some people wearing personal protective equipment have still contracted Ebola.
It's an obvious fact, yes.
So some risk individuals have no mandatory restrictions on travel or public activities. In fact, there's no requirement for returning healthcare workers to self-isolate or avoid public transportation like subways, bowling alleys, et cetera. I might want to add, we've done a survey of members on this side, and every single member who asked hospitals in their district has returned comments saying that all those hospitals said for those first 21 days, those healthcare workers are not going near a patient. They'll be furloughed, they're to stay home, take a temperature multiple times a day. Do Samaritan Purse healthcare workers follow guidelines such as this when they return?
We actually have written our own protocols and guidelines back in late July when Dr. Kent Brantley, who's testified here, was coming back. We were bringing out about 40 people. We contacted CDC and asked them what their protocols were. And frankly, They told us just to have our staff check their temperature twice a day, and if they got a fever, go to the local health department. We didn't feel that that was adequate because we had just come through a very serious bout with Ebola, and I think we probably had a more realistic encounter with it than perhaps other people had. So we created our own protocols. We check our staff through direct monitoring every day, 4 times a day. We have a little bit lower threshold, and we do keep them in a restricted movement, no-touch kind of protocol for 21 days.
So you're saying that your protocol goes beyond the CDC recommendation?
There's no question our protocol goes beyond the CDC.
Well, CDC says that's not necessary. Do you agree?
Well, you know, all I can say, I mean, there was a question a minute ago about CDC, you know, disregarding what we're saying. CDC is a large organization. They create a policy. So if you call them and say, well, we think we ought to do this, they say, well, that's not our policy, and then they don't engage any further. That's just the reality that we have run into, and I don't mean any disrespect to CDC. I'm very appreciative of them. But for us, we live in a small town. So our national headquarters is in a town with 40,000 people. What we have ran into is that the spouses of some of our returning staff don't want them coming home. The returning staff don't want to be around their children. And we don't want to spook everybody in our community.
So you're erring on the side of extra safety?
We are, yes, sir. We're.
Let me ask another thing. This has to do with discussions I've had with Franklin Graham, son of Billy Graham, and highly respected individuals here. But listed that there are some problems for people, the NGOs, the charitable workers, et cetera, as well as government workers traveling back and forth to Western Africa. Is that a fact that there is difficulties with travel?
I think that is one of the greatest vulnerabilities that the United States has to fight the disease in West Africa. There is not a dedicated humanitarian bridge. What has happened, I mean, there's been a lot of talk about, well, a 21-day waiting period would make it onerous for volunteers and they wouldn't go. I'll tell you what will make it very onerous is for volunteers not to have an assurance that they can get a flight out. I promise you they will not go.
How many airlines can currently fly in and out of Western Africa? I heard it's like Sabrina Air. And
well, I think it's 150 or 200 a week, according to what he was saying. That's general population. I don't know how many relief workers.
But we don't have a bridge for the relief workers.
There are 2 airlines that fly in and out of Liberia. One is Brussels Air, and by the way, when you get off in Brussels, you just walk. You go anywhere. You're not monitored for anything. And the second one is Air Maroc, Royal Air Maroc. If they should decide it's not in their commercial interest to continue flying into Monrovia, then there will become an effective commercial quarantine on Liberia. Then what's the backup plan?
Plus, as I understand that getting supplies to West Africa is a huge problem. I understand that they had twice had to lease planes.
2 747s
at a cost of
about $460,000 apiece, and each one can take about 85 tons. And but logistics in and out for cargo, logistics in and out for people, I think we have a great vulnerability there. There is one organization that is flying like a nonprofit. They've done 4 flights. That's great, but that's not enough.
So make sure I understand what you would recommend is that the United States government could help sponsor a charter flight twice a week from the United States to Africa, from Africa to the United States, so that workers, government workers, volunteers, NGOs, et cetera, would have a clear bridge, in which case they could be tested before they get on the flight, tested during the flight, tested when they land. At one point, the United States would simplify this whole process. Am I correct?
I 100% support the concept of a dedicated humanitarian air bridge from the United States directly to West Africa. Now, there would be 1,000 details to work out, but we have a vulnerability. If Brussels Air stops flying for their commercial reasons, we will have no air access.
Thank you. I'm out of time. I'll yield to Mr. Green for 5 minutes.
Thank you, Mr. Chairman, and thank our panel for waiting today. And to follow up, I think that it would also be more certainty because instead of, like you said, going to Brussels or somewhere else and just walking around, it would be the testing. And I assume these healthcare workers would love to have that because they don't, like you said, they don't want to infect their own families. Dr. Lakey, let me thank you because I know a few months in October there was a lot of, it seemed like unusual statements being made about Ebola, but when the state of Texas made the decision on how you would develop the protocols right after that, I appreciate that because it really sounded like everybody was getting back to normal and saying, okay, this is an illness, we're going to deal with it, and this is how we can do it. So I appreciate the state doing that. But let me go on to some questions. Dr. Gold, one of the interests I have, and I said earlier, is that how did University of Nebraska develop this facility? I think it was opened in '05, and was it a combination of state, local, university funds, federal, to develop the largest containment lab in the country?
Thank you. The unit was opened in 2005. It was planned shortly after the 9/11 events, the anthrax scares, and it was done predominantly on university funds, to some small extent on state funds, and I believe there were some federal Department of Defense dollars involved in the planning as well. However, very importantly, the maintenance of the staff, which cost us approximately between $250,000 and $350,000 a year to maintain the preparedness, has been totally borne by the university and the medical center.
Well, I appreciate that because the leadership, and I'm just surprised that no other university would take that lead, and I appreciate Nebraska doing. Now, my colleagues, both Congressman Terry and Joe Barton, know my daughter's there, and she was recruited to come up there in '09 and I appreciate, well, and although when she told me back in the '90s she wanted to be an infectious disease doctor, I said, I don't want you to treat me for anything you know about. But she's like most medical professionals, that's her job. And we want to make sure we protect them to do that. And Nebraska Center now has treated several patients, and what is the spending is required to prepare the hospital to treat an Ebola patient?
The direct costs that we've experienced, and we've compared notes pretty closely with Emory, and we're not far apart, is approximately $30,000 per day for each patient admitted. The average length of stay, I guess it went down over the weekend a good deal, but for the two patients that went home was 18 days, and they were both treated in the relatively early stages of their disease. And that's the direct cost of equipment, supplies, nursing care, et cetera. And as I say, that's extremely close to the number that the folks at Emory have come up with. That does not include the cost of the preparation, which I just referred to, and it does not include the cost of what I would call the opportunity cost, which is this is a 10-bed unit that is otherwise used for medical surgical admissions that would otherwise be completely full with routine patients receiving their care.
Okay. Are the policies that were in place prior to the current Ebola outbreak still in use, or has the University of Nebraska Medical Center made changes to its protocol and guidelines based on literally real-life experiences?
We do evolve our policies and procedures. We learned a lot from each of the patients, particularly the first patient that we housed. We, for instance, put a completely self-contained laboratory unit into the biocontainment unit so that laboratory specimens are not transported outside of the unit. We're also very privileged, and I know there's been a lot of discussion about waste management, is we can decontaminate all of the waste as it leaves the unit, so there is no transportation of any infectious waste material outside of the unit, which makes it much safer for the community, and it also makes it much less expensive and for us to have that built into the unit. And this was only because the unit was planned as it was constructed prior to 2005, understanding that the disposal of infectious waste would indeed be a big problem from logistical as well as expense, and therefore it was self-contained.
Mr. Chairman, I know I'm out of time, and I appreciate, because from where we were at 6 weeks ago, we've actually evolved, and I'm glad the experiences we're actually learning from them. And I appreciate our panels being here today.
Thank you. Gentleman yields back. Now recognize Dr. Burgess for 5 minutes.
Thank you, Mr. Chairman. I want to thank all of our witnesses for being here today and bearing with us through what has been a very long but very informative hearing. Dr. Gold, there is a difference, though, between the type of patient you get at your center, because they're referred. There's not a direct access where someone thinks, oh, I've got Ebola, I'm going to go to Dr. Gold's center in Omaha. Mr. Duncan came through the Presbyterian emergency room with all of the other patients that came in that Thursday night and had to be, his case had to be winnowed out of all of the other load that was in the emergency room. But in your situation, a patient only comes after they've been identified. Is that correct?
Thus far, the patients that we have admitted to the biocontainment unit have all come with a diagnosis, a PCR diagnosis of Ebola. However, given our national reputation, the number of phone calls, emails, even emergency room visits has actually been quite interesting, with people with febrile illnesses saying, please tell me if I have Ebola.
Well, let me just ask you about that then. So then patients who arrive in your emergency room, I mean, you outlined how you have almost a dedicated laboratory handling of the specimens from an Ebola patient, but that's someone you know about. If somebody comes to the emergency room and they've got fever, they've got headache, and they've got all of these other complaints, I mean, in addition, if someone thinks to do the PCR Ebola test, but in addition, they're going to get a CBC, they're going to get a urinalysis, they're going to get any number of other blood tests. And these tests would go through the normal auto-analyzers in the lab without knowing that that patient actually had an Ebola possibility, or is that in fact separated out in your emergency room?
Yes, sir. We have put protocols in place, and we've also widely shared them for triage screening in the emergency department. If there's any suspicion that a patient either has a travel history or a symptom complex, they are immediately sequestered. There's a specific nursing protocol for personal protective equipment, etc. There's a notification of the team, and the laboratory specimens are processed through the biocontainment unit facilities and then decontaminated as if they were positive, even before we know the results of the PCR. And we are doing PCR testing on site now, which makes it a lot faster and a lot easier. Otherwise, it would have taken days previously.
But again, I would just point out that, I mean, that is in a perfect world. In the rough and tumble Muleshoe, Texas ER, that all of those protocols would not immediately be available. And we'll get back to that, but Mr. Isaacs, I actually have to ask you, I mean, the Typhoid Mary analogy that you used, that's the first time I have heard of that. Now, we all remember Typhoid Mary of lore, and she actually had the ability to infect people. Do your Typhoid Marys carry the ability to infect people when they themselves are asymptomatic?
We don't know. That's the question. Now, Typhoid Mary, in the case of her, she was dealing with a bacterial infection.
Right.
But what I do know for a fact is that there have been a number of asymptomatic, non-febrile people whose blood have been drawn and they tested positive. And I think that there is something about the PCR test that, I heard Dr. Frieden say in medicine you never say 100%. The thing with with Ebola, if you don't bat 1,000 every day, somebody dies.
Right.
And
someone else is exposed.
Yes. My point in saying all of that is not to raise fear, but it's saying that we need to go to Africa and beat the disease over there.
Yes, sir.
We need to keep it contained.
You raise a point of 2 of your doctors were infected and you weren't sure why. We had 2 nurses in Dallas were infected and we're not sure why. And again, that just underscores that there is probably more not known about this disease than what is known, and that's again why I began this with we all ought to step back and have a little bit of humility. I would even extend that to Mr. Waxman, and he not known for his humility. We all have to have a little humility in dealing with this. Dr. Leakey, I'll just have to ask you, I mean, what you did in Dallas to sort of restore good order and discipline at a point where it really almost veered toward being out of control. I mean, it took a lot of courage to exercise those control orders on the individuals when you did that. And I will admit to being somewhat surprised turning on the news and hearing that had happened. What were some of the things that went through your mind as you developed that?
So we don't take control orders lightly. And so in Texas, I can put a control order. It's not enforceable until I get a judge to enforce it. But we have to get the monitoring done in an event like this. We have to make sure that people do not have fever. And if I could not get that done the way that I needed to protect the public's health, I take taking the public's health extremely seriously, and so we put a control order in place. Now, if you do that, you need to make sure that you provide the support services around that individual to make sure that there's food, other support there, so you can make sure it's as humane as possible. With the nurses, following the nurse that became infected, we again needed to make sure we had monitoring in place. But we also, as we looked and stratified risk, it looked to me like the biggest risk was being inside that room with Mr. Duncan. And so for those individuals, we said it's best during this time period that you don't go into large public congregate settings, movie theaters, churches, et cetera. It becomes a very large epidemiological evaluation when that occurs if unfortunately somebody becomes infected. And we're able to work with that staff, and they took this very seriously to be able to limit their movement for the highest risk individuals.
Very good. Dr. Gold, are your patients reimbursed by insurance, or are you reimbursed by insurance when patients are referred to you?
We are in the process of having those discussions with the insurance carriers and with their employers, but to date we have been unsuccessful in any reimbursement through a commercial carrier. And I can't really tell you whether anything's happened in the last 24 to 48 hours, of course, but they have not responded.
Thank you. I appreciate that.
Hey, Mr. Waxman, recognized for 5 minutes.
Thank you, Mr. Chairman. I'll take 5 and maybe take additional 2 like we saw for the other questioner. Earlier this month, President Obama sent to Congress a $6.2 billion supplemental budget request to enhance the U.S. government response to the Ebola outbreak. The President's request is intended to fund both immediate and long-term needs in the United States and West Africa. Dr. Gold and Dr. Lakey, you can both speak to the readiness of our public health system here in the United States. The President's budget request designated $621 million to CDC for domestic response, including funding for state and local preparedness, enhanced laboratory capacity, and infection control efforts. It also designates $126 million for hospital preparedness. Dr. Lakey, can you comment on the need for additional funding for state and local public health authorities? What are the top funding priorities?
Thank you, sir. As I outlined in my comments, state public health, local public health is having to do a lot of work right now. The laboratory response network, having the laboratory system out there so we can rapidly diagnose individuals is essential for us to make the diagnosis and isolate individuals. The epidemiologist that contact individuals, talk to them, figure out the risk is essential. The hospitals having pre-designated facilities so we can care for those individuals is very, very important. This isn't the only event. We've had multiple events, fertilizer explosion, Hurricane Ike, et cetera. That system to be able to rapidly respond is essential. Now, a lot of that's paid for by HPP funds. My HPP budget was reduced by 36% this last year. And that pays for the training, the education, the things that take place in order for the hospital systems to be ready.
I wanted to ask Dr. Gold for his response. Would additional funding assist in hospital preparedness? And give us some examples of areas where additional funding would be helpful.
I think the additional funding would be helpful to build the educational programs, to get the referral centers as well as community hospitals completely up to speed. The additional fundings will allow to scale response in event we need to bring American soldiers or other volunteers back to the United States. Additional funding will be used to create preparedness for future infectious crises of this nature, for which we currently do not have resources, and to build a sustainable infrastructure such as convalescent serum reserves, such as core laboratory testing, et cetera, so that we have and sustain a national preparedness level.
Thank you. I want to pivot now to the funding for international efforts. Mr. Isaac Samaritan's Purse has been on the ground in Liberia since March and understands the environment there. I want to talk to you about the NGO perspective on continuing needs and efficient use of resources. What are the main priorities on the ground in West Africa, and what resources are needed to accomplish those efforts?
So if I may just add something to what you said, we've actually been there for 11 years, and the disease broke out in March. So we've got a large footprint. We've got 350 staff, about 20 expatriates. We have aircraft there. We have a lot of capacity in the country. And when the disease broke out, we 100% focused on fighting it. What we are seeing today that we think that other resources are needed for, this is very practical, but you know what? Logistics are everything. And there is a lot of discoordination and confusion right now between the UN players, UNHAS, UNMIR, and the DOD about gaining access to airlift. There are no protocols in place about moving blood samples. So if CDC goes out into an area and identifies a new village and there's 10 or 12 people who test positive, they call us in because we've assembled rapid response teams. We're not able to take the blood samples out through other aircraft. We have to move them out by land. A rapid diagnostic test is one of the greatest things that are needed there, and I think, frankly, that if the U.S. military was running the coordination cell, things would get much, would be done quicker.
Well, the U.S. is helping and committed to helping in Liberia and has provided personnel, resources, and funding. As we continue our aid efforts, we must also keep in mind the need for a flexible response. Initial reports indicate that there are empty beds in Ebola treatment units in Liberia, so the aid efforts have adjusted accordingly to monitor occupancy and only build additional ETUs as needed. Mr. Chairman, I hope that we can join together to quickly pass the President's budget request. We heard from this panel and we heard from our first panel about the urgency of the task at hand and the public health catastrophe that will occur in West Africa if we fail to do so. Thank you very much, and yield back the balance.
I appreciate that. Certainly I'd like to see that happen too, and I hope you also take a careful look what Mr. Isaacs' group is also looking at. They need a bridge to move people back and forth because that's a struggle right now. I'll recognize Mr. Long for 5 minutes.
Thank you, Mr. Chairman, and I thank you all for being here, and not only that, but what you do on a day-to-day basis, because I, for one, really appreciate it. Dr. Gold, you said, well, let me ask you something before that. Dr. Martin Saleh, is that how it's pronounced?
Yes, Saleh.
Saleh. Dr. Saleh was taken to your facility, correct?
Yes.
And the reports that we got on the news, turned on the radio, and they said that there was a doctor with Ebola that was very critical, was the first thing I thought. And I probably had the same thought a lot of people did. That's probably not a good thing when they say that he's very critical. He later deceased just a few days later. And I apologize, I had to step out of the room for a few minutes, which I normally don't do. I'm usually here for the whole duration of these hearings. But was there a reason that he was delayed coming to this country for assistance, for help? Do we know? Because that seems strange that he would be that far gone, so to speak, before they would think about flying him out.
It's unclear to us what the logistics were that might have delayed it. As we are told that he had an initial blood test for Ebola that was negative, and only 3 days later did he test positive. And when he tested positive, there was a period of time before at least we were contacted. I don't know whether the transportation organizations or the State Department were contacted, but from the time we were contacted, the plans for transfer were put into place virtually immediately. There was also a good deal of uncertainty how stable he was immediately prior to transfer, but once the decision was made to transfer him, rest assured that he got every conceivable treatment.
I'm sure he did, and I wasn't implying that at all, but I was just curious as why they waited as long to try and get him a sick. Because when I heard that first radio report,
I am told that
very critical.
that it's
like
not
I say,
uncommon for people to test negative during even when they're symptomatic. We've heard about other people who have tested positive who are asymptomatic. This is not 100% certainty disease, and we're learning an awful lot about the spectrum of how symptomatic people get versus their viral levels, et cetera.
Let me stay with you, Dr. Gold, and switch up the topic just a little bit. You said in your written testimony that you've coordinated extensively with the CDC and HHS on readiness and treatment. Can you tell us more about that collaboration? On what specific issues have you advised the administration?
We are working with Emory, with the CDC, and with ASPR on standing up educational protocols, visiting other institutions across the United States to help them enhance their readiness, hosting teams from other institutions across the United States. In Nebraska, we've recently had a team of 9 or 10 people from Johns Hopkins University, as well as putting together a series of protocols that would be used for, if you will, accreditation or certification of readiness and maintenance of readiness.
And when you say you advise the administration, have you spoken with Mr. Klein, the new czar, the Ebola czar?
Yes, sir, several times.
Okay. And did the administration, did they incorporate or accept your recommendations? And did they reject any of your recommendations?
We're working specifically with Dr. Lurie, who was your guest here a little bit earlier, and we speak probably daily on the development of these protocols. There's a conference call that's scheduled for Friday.
So you feel they are accepting your recommendations?
Thus far, yes, sir.
Good, okay. And Mr. Isaac, we were talking about earlier, or you were in your testimony, people traveling on planes and being checked temperature-wise every so often, 3 times a day, did you say, or what were?
Our staff are under protocol to take their temperature 4 times a day.
Their own personal temperature?
No, we actually have staff in our Ebola task force that call them every day, and we keep a log of it. I could call my office right now and tell you where every one of our people are.
But you're talking about your staff, not their patients?
Yes, our staff.
Okay,
not sick.
okay.
Yeah. We're just monitoring their health.
Right, okay, good. Okay, I misunderstood earlier because you hear these reports about, well, we'll check their temperature when they get off the plane. I think we need to do a travel ban, as I've mentioned before, but if they say we'll take their temperature and then they say they can not be symptomatic, not have a temperature, and still have Ebola, so my question is probably invalid since you're talking about your staff. But anyway, thank you all again for your service and what you do and for being here today. Mr. Chairman, I yield back.
Thank you. Mr. Griffith, you're recognized for 5 minutes.
Thank you, Mr. Chairman. I appreciate that. Thank you all for being here, and thank you, Mr. Isaacs, for the work that you all have been doing there for 11 years. Samaritan's Purse is a good organization, and appreciate what you all have done.
Thank you.
Not just there, but around the world. Speaking of that, in your written comments, you said many public health experts are telling us that we know the disease, how to fight it, and how to stop it. Everything we have seen in this current outbreak, however, suggests we do not know the science of Ebola as well as we think we do. I touched on this earlier in the previous testimony related to, I believe, the reservoir species is what Dr. Frieden was talking about, and that we don't know the full extent of the reservoir species. And you touched on that in your written testimony as well. And you asked the questions, can the virus live in other mammals besides primates, bats, rodents, and humans? And you attached a study that related to pigs. Do you ask this question because your people on the ground have some questions, or just because it's a blank slate and we really don't have much research on it?
I think that Ebola is potentially a much more serious disease than it is given respect for. What we are seeing is that it is flexible, it is deceptive, it's sneaky, it's agile, and every time somebody thinks they have it figured out, it shows us something new. And I think that we, as a society, cannot make assumptions that we know what it is and what it will do. I think that we need to be extraordinarily careful about letting it come onto this shore. And while it is true that when it has come here, we quickly identified it and isolated it, the truth is, as these doctors could tell you, particularly the gentleman from Texas, that if he had 10 or 20 or 50 cases down there, it would consume his capacity to isolate it. And so while we can isolate it, if it were to get out from under us, it would quickly exceed our capabilities. And that's why I think it is so extremely important to invest resources to fight and stop this disease in Africa before it gets off that continent in a major way.
And I appreciate that. Have any of your people there in Africa indicated to you that they're concerned about animals that might be carrying the disease, or is that just a question?
We live Ebola 24 hours a day. It's all we talk about. We talk about it all.
Right.
And yeah, we are worried about it. We don't know. Evidently in Spain, they thought the little dog, they killed it. In Texas, you put it in isolation, and I'm glad the lady got her dog back. I'm a big dog guy. But who knows? Maybe there's some science on this, but I think that we don't know.
Well, I would refer you to a study that came out in March of 2005 in the Emerging Infectious Disease. I guess that's the name of the publication, but it's a CDC publication. I'd be happy to get you a copy of it. And it's available, where they talk about the potential of dogs, and it says that although dogs can be asymptomatically infected, in other words, they don't get the disease, and sometimes the science gets confused on television. They don't get the disease, but they're carrying the antibodies for the disease. And this study says asymptomatically infected dogs could, doesn't say they are, could be a potential source of human Ebola outbreaks and a virus spread during human outbreaks, which would explain some epidemiologically unrelated human cases. And it goes on and it talks about there are cases in the past in Africa where they don't have any idea where the disease came from. And I asked Dr. Frieden about that, and he said that, you know, maybe bats, but they still don't know what all the reservoir species are. In a prior hearing before today, when we were here in October, I said, you know, what are we doing about animals coming into this country? And it was more or less laughed off, but it is a concern. Wouldn't you agree, Mr. Isaacs?
I do agree, and I'll tell you why it's so important. This is not the flu. This isn't influenza. This is a disease that kills 70% of the people that get it. And if you look at what the disease has done this year, and you know, 5,500 people dead, 13,000 cases, that's extraordinary. And none of us have swam in these waters before, and I don't think that we can use case studies that come from 1976 to today to make assumptions about an unprecedented event that crosses national boundaries. It's now in Mali. When you look at the disease, the caseload may be going down in Liberia, but the disease is in fact spreading geographically. We fear that very soon we will see it in Sierra Leone, and it's already been identified in Mali.
Well, and I appreciate your comments on that, and I liked your term travel management, because I do believe we want people to be able to get there to provide humanitarian relief like your organization does. At the same time, I think we have to be very, very careful. With that, Mr. Chairman, I yield back.
Chairman yields back. Now recognize Mr. Tonko for 5 minutes.
Thank you, Mr. Chair. State and local health departments and local hospitals serve at the front lines for treatment and containment of infectious diseases in the United States. In the case of Thomas Duncan in Dallas, the country saw the challenges faced by local health departments and local hospitals dealing with an unexpected infectious disease. So, Dr. Lakey, now that you've had some time to reflect on Mr. Duncan's case and how it was handled, can you talk about some of the challenges Texas Health Presbyterian Hospital faced in terms of preparedness?
Yes, sir. I think the first challenge was to recognize the first case ever in the United States, a rare disease in the United States. Everyone was watching what was occurring in Africa, but to think that that was going to occur in your emergency room on a busy night was a challenge. I think there was a challenge related to the national strategy, and I say national because there's experts outside of government that review those strategies on infection control. But the assumption that any community hospital can care for an individual that has that much diarrhea, that much vomiting, with that much virus in those fluids, I think was a faulty assumption. That it took a really dedicated team to be able to care for that individual. I think one of the lessons learned was healthcare, nurses, physicians, they take their responsibility extremely seriously, and they showed up to take care of Mr. Duncan and their colleagues. I think a lot of people were worried that healthcare wouldn't show up, that healthcare providers would not show up, but they showed up. Mm-hmm. I think there was a lesson related to the level of personal protective equipment, and that was changed, and so a higher level of personal protective equipment. And I think we learned that you don't have to wait for a temperature of 101.5 to diagnose the individuals. We lowered that temperature threshold because we wanted to make sure we identified individuals early, and we identified them with temperatures about 100.6, 100.8, which by the previous guidelines wouldn't have met the criteria for testing. So those are just some of the lessons, sir.
And in what ways could the Dallas and the Texas state public health departments have been better prepared to handle an unexpected case of Ebola or any infectious disease?
Yeah. So I think there's several components to that. I think the the necessity to train. I think health departments across Texas and across the nation had been preparing. There was a lot of information that we had been sending out, but that's different than saying this is a real event and I have to be ready right now. I think one of the things that we're doing right now to make sure we improve our preparedness is not only making sure that all hospitals are ready to think that Ebola is possible and in the differential diagnosis, isolating those individuals and informing individuals, but make sure that there's a system across the state where those individuals then can be seen and be tested before you get to a level of a hospital that can care for those individuals. No hospital wants to be an Ebola hospital. It's just hard on your, getting other individuals into your emergency room if you're labeled the Ebola hospital. And so there's some reluctance across the United States to step up and be that facility. But that is one of the things that we're working on right now.
Thank you. Dr. Gold, as you said in your testimony, University of Nebraska Medical Center is recognized as a national resource for your readiness to provide care for Ebola patients. You have successfully treated Ebola patients, and just last week another patient who sadly passed away was brought to your facility for treatment. Can you briefly describe the protocols and procedures UNMC had in place that ensured staff was appropriately prepared to care for Ebola patients?
Yes, sir. Since the unit was stood up in 2005, the staff of between 40 and 50 people has been sustained, and that staff meets on a monthly basis to go over policies and procedures, emerging trends in Africa and South America, et cetera, and as well as works closely with the military through STRATCOM and the Offutt base. But that team also drills 4 times a year, and they do real exercises in the community with waste disposal, with paramedic transport, et cetera. We also practice donning and doffing, use of various types of personal protective equipment, dialysis, respiratory management, et cetera. So all of the typical procedures and protocols are not only learned, but actually practiced hands-on, real-time, at a minimum 4 times a year for every staff member.
Thank you very much. Mr. Chair, I yield back.
Thank you. Mr. Terry, 5 minutes.
Thank you. Dr. Gold, what are the costs and impacts of being prepared when you are preparing and practicing 4 times a year when all of those pieces within the community are also participating?
The actual out-of-pocket costs have been calculated to be between $250,000 and $350,000 a year to maintain the core team of nursing support, techs, respiratory therapists, et cetera. That does not count the in-kind time that our physicians and other leaders put into it, as well as does not count the time of the maintenance of the unit, the air handlers, water supply, autoclaves, maintenance of stock of equipment, et cetera. That's just the personnel time that goes into maintaining the readiness.
And in your opening statement, and I hinted this in one of my questions to the CDC, is that for the level of facilities that UNMC and Emory are, and when you train and practice like this, there should be some maintenance funds to offset those costs?
Well, we certainly agree with that. I believe that the CDC over time has had a relationship with the Emory organization predominantly to protect the employees of the CDC that work with highly infectious agents in their testing laboratories and around the world. We have not had that type of relationship and would think it would be appropriate perhaps through the UARC structure or through some other vehicle that exists.
Are you being homered?
Sorry?
Emory being in Atlanta and CDC being there, is that, are they just giving money to the hometown hospital? Or is there some contractual relationship? I think that they needed
just like we need a way to take care of our employees if something tragic were to happen and they were to become ill, they need a way to manage their employees as well. And I think that was the original basis of the relationship. We would very much enjoy a similar relationship.
Yeah, and I think you are on equal, if not better footing, medically speaking at least. Speaking of that, just to pick your brain a little bit here, and maybe someone's already done this, but you've had 2 successful patients that got to hug all the doctors and nurses that helped them, and then we had the last patient that came in that appeared from the TV video to be in supercritical condition. What, in your opinion, is the reason that perhaps this physician, latest patient, passed away? Any takeaways from being how you were able to treat the first patients versus this one that came in a more critical condition? Any lessons learned?
I think the most important lesson learned is that the earlier we have access to treat any patient here or in Africa, the better the yield is going to be. This particular patient had renal failure, liver failure, was unconscious when he arrived in the United States. And what we've learned is that those are all very bad predictors of outcome. The earlier patients that we cared for did have early organ failure, but were reversible through good supportive care, and they all received experimental medication, as did this patient. But I believe that the organ system failure we dealt with over the weekend was just far too extreme.
So, I mean, with just this one example, it's probably not certain, but is there just a point of no return with an Ebola patient? Their organs have already shut down. Is there a way of treating them so they can survive, or is it just at that point not survivable?
I don't think it's possible to predict young people. This gentleman was in his early 40s, and the thinking was that it was worth an all-out effort to attempt to save him. And I don't think if you could take the exact same patient twice that you could predict the outcome.
Yeah. Very good. Appreciate it. And Dr. Gold, you and Nebraska Medicine and UNMC make us proud. I appreciate all of your efforts.
We have a great team. Thank you, sir.
You do. With Mr. Green's daughter.
Gentleman yielding back?
I yield back.
I'm going to recognize Mr. Green for 1 minute of wrap-up.
Thank you, Mr. Chairman. I ask unanimous consent to place in the record a statement by the ASHFE, the American Federation of State, County, Municipal Employees, urging Congress to support the President's emergency funding of $6.18 million.
Without objection.
And, Mr. Chairman, I want to thank our panel, both panels today. I know the first one's gone. Oh. I just appreciate our witnesses being here, but also for the panel that was put together, and that's what our Oversight and Investigation Committee is supposed to be doing, and I appreciate it. But to follow up on my colleague, I'm the first time in history that the intelligence from your children went back down the tree, and so I just appreciate that first time in mankind. So, thank you.
So noted for the record. I want to thank this panel. You have, you can give you 30 seconds here? Go ahead, Dr. Burgess.
Well, I was going to thank the panel, too. I mean, I have been through a number of these hearings. Our committee, of course, has done hearings. I was allowed to sit in Homeland Security, and they did a field hearing in Dallas. I sat through the hearing on Foreign Affairs last September. This has been the most informative panel that I have had the pleasure to hear from, and I really appreciate. I know it was a long day, and I know we made you wait a long time, but I really appreciate you guys sticking with us and sharing with us the information that you shared, because it's been absolutely critical, and I'll yield back.
Thank you, Doctor. I want to add to that. I almost had the feel that the first panel we had today was spiking the ball. We got this, and we can be confident, and I don't agree. After we had our hearing several weeks ago, put forth several recommendations. Among them, we needed some level of travel restrictions. People ought to be isolated for 21 days, and what I hear, Mr. Isaacs, Dr. Lake, I don't know the same for Dr. Gold. Not only did you do that, along with the hospitals of so many colleagues, but your employees didn't complain. They recognize they don't leave their compassion at the borders of Africa. I thank them for that selflessness, that altruism, not only while they're there, but on returning home. From this, several takeaways. The people with level 4 gear can still get Ebola. We don't know all the routes. And what we don't want to have is a false sense of security, that everything's fine. I worry that the first hearing, this room was packed with cameras and people in the press. At this point in the hearing, what you've told us should still tell us we have to keep our radar up, full alert here. We have a major battle for this taking place in Africa with a very difficult time for getting people in and out of there. And if any of those airlines stop their flights, could happen at any moment, we're at a loss for moving people and supplies in and out of there. So along those lines, I hold to it that we should still have people do 21-day restrictions from touching patients when they come back. I'm glad that hospitals are doing that anyways. I hate to think what would happen if that did not occur. And quite frankly, I think the hospital would have to tell other patients that if they did have some employees who are recently with Ebola patients. But I also want to echo Mr. Isaacs, and I'm going to try and work this out, that we ought to have a bridge for people going to and from Africa, for all your selfless workers from so many charities, Catholic Relief and Methodist and so many other groups I've heard from, Doctors Without Borders. We need a way for them easily to go and easily come back, and we can help monitor them. So this is one less thing to worry about. With the amount of money we're talking about going through this, I quite frankly, especially when you look at $20 million going to New York City just to monitor the people exposed to that doctor, that would pay for a heck of a lot of flights, and we could have a charter system to do that. Please stay in touch with us. Committee members will have 10 days to get to other comments of the committee, and they will also have questions for you, and we ask that you respond quickly, if in a timely manner, with any questions to the committee. And with that, again, thank you to the panel, and this committee hearing is adjourned.